But just to get everyone up to date, I already told Martin, right after we broke from class, I sent screenshots of basically trying to add the emails for those students to our IT POG. It usually takes them a few days to get back. So we want to get this, there's no communications, missing. But in the meantime, congratulations for those of you kind of stepping up and passing on the word for people who aren't getting it. You guys are being a great team. Can't say it enough. You guys are just outstanding class. So it's really nice to see. And on that, I'd like to get to Andy Escalona. Get your RCCD address.
Oh.
And till he gets back, I got E. Dixon 7, J. Castillo. Get one at rocketmail.com. I've never heard of Rocket Mail in my life.
Sir, that would be me.
That'd be you? Corredo,
yes,
what's your RCCD address?
It's going to be J. Corredo at rccd.edu. Or, sorry, student.rccd.edu.
I can get the rest of that there. That'll be good. So at least you don't have to put like a number after your name. That always drives me nuts. So JCARRETO at student. And we got Bowie. You got Butker, Bo.
Yes, sir.
What's your RCCD address?
It is. Sorry, I'm pulling it up right now.
Well, mine is C Bowie 5.
I'm looking at Butker's right now. Please place.
Oh, okay.
I'll come back down. So we get
it is RBOETTGER1 at student.rccd.edu.
Roger that. And now we have, I think M. Barber confirmed that was the case. And then we had Aguilera Roberto, 1997. What was your year of birth?
That is correct, 1997. But do you want my student ID?
My daughter was born in 97. What month were you born?
October.
Oh, and she's older than you. It's amazing. But you're doing more than she is, so that's good. All right, so what's your rccd.edu address?
It's R Aguilera 10 at student.rccd.edu.
Okay, so I'm going to go. It's R like Raguilera, RAGUILERA 10.
Correct.
Okay. Now going to those that I missed.
Thank you, sir.
Andy Escalona. Is he there?
Yes, sir. It's going to be A Escalona 2 at student.rcc.edu.
So that sucks. So you're the third A Escalona, huh? In the school system.
Really?
I'm assuming unless it made you use a 2 at the end of your name. Christopher Fox at gmail.com.
Christopher A. Fox at gmail.com.
Okay, what is your, not picking up the hint here, your rccd.edu address?
K. Fox 6 at student.rccd.edu.
So at kfox, the number 6 at student.rccd.edu. Cool.
That's correct.
And then going all the way back down to Robinson again. What is that?
My email is jrobinson100 at student.rccd.edu.
Okay. Oh, let's see. So JROBINSON 100.
Yes, sir.
Okay. Who do I have left? I think that's it. We've got nothing but edus in this row. So I will work on getting those put in again and see how that goes. I apologize for chewing gum, but I have bad breath right now, so I don't want to Mess y'all up. Courtesy laughs are always appreciated. Let's see here. Okay, so one thing I'd like to go over, because this is kind of fundamental, is over the quizzes. They're graded. I just haven't put the grades in yet because there was some real bonehead mistakes in there that reveal major lack of understanding of stuff, and I want to nip that in the bud now. Everything's kind of empirical. And if I understand empirical right, it means things build on each other. And hopefully today with the assessment, there were a couple of you guys that did really, really good assessments. I want to say, who was the kid who kept getting knocked off on the, where are you? Oh, one of you. Anyways, you're kicking ass in your assessments. And then the mustache also did a great, Melendez, great assessment there. And it was Ferguson. I think you were doing really good too. So overall, really good. And just this morning, we're going to just go from now on to just 4 classes on Zoom days. Because now that we know that I can't basically run a class and then keep exiting rooms to put fires out, it's just going to be 4 people. So there'll be a little bit longer. So you'll have Mr. Duncan, Nolan, White, and Leon, and I'll be floating around. And then Friday, or the regular in-class labs will still do 5 sessions. Next week, we're going to be introducing you to, for some of you to be new, the oral tracheal intubation and the King Airway. Those skill sheets will be posted as soon as I update those today. I want to make sure they're even better. Good job, mustache. So that'll be the case. So the before I go off anymore, I'm open up to you guys as far as any pressing questions, whether it's from this morning's class or something that's stuck in your head now that you've had a chance to settle down a little bit. Everyone good? Okay. So then coming from me to you, I kind of wrote it briefly. I've learned some tricks just like everyone else as far as kind of uploading those videos, and that screwed me up into getting your assignments late. So you'll notice that you didn't have really any assignments except to basically get your stuff ready. I swear I wouldn't make that mistake again. So I'm not here to make your lives miserable. Any homework I give you is for a reason, but if it's going to be overwhelming, then that's kind of not really helping things. That said, those videos were posted there for a reason. So if you haven't looked at them, I'd recommend you at least give them a passing look because it'll come up later. But thank your class president for that, because he's been a real a leader in this way. And he kind of hits me up and says, hey, this stuff is getting late. So you guys talk to him, he talks to me, and it works out well. And that's what this is, a collaboration with all of us. There's not just 29 or 30 students, there's the whole group of us. So thanks for the feedback on that. And again, my apologies. So that's why I made sure to get all the work out last night and this morning. Going to the preload and afterload. Are you guys getting sick of hearing those words?
No,
Good.
sir.
Is anyone? So I'm not going to ask, because it seems like if I just ask, there'll be, it's kind of becomes a rhetorical question. So I'll say it again, and you'll see it again, because it's so fundamental to getting anything down when it comes to circulation. Preload, the easiest way I could think of it is like if you think of a slingshot, if you put a rock in it, you draw it back, or like a bow, that's your ventricular stretching. And using Starling's basically law is your prime, is your loading, locking, whatever the hell you want to call it. Normally we talk about preload with respect to the right heart, and then afterload on the arterial side of the left side of the heart. But in reality, you have a right ventricular preload and you have a left ventricular preload because both ventricles work. So when you see your video this week on the pulmonary embolisms again, because the kind of shock aspect kind of throws people off, and that was a point of discussion, the video does a pretty nice job of showing how an embolism can actually cause an increased right heart preload. And that, because the right heart isn't really designed to push a lot of stuff, it actually overwhelms the right heart. And EKG-wise, that's what accounts for kind of some of the changes. So it's an easy graphic to see. You'll see it's a pretty simple cartoon, but it's important that you get that set in your head. Afterload is whatever the resistance is, the heart is pushing against. So if it's the right ventricle, okay, what organ would cause increased afterload to the right ventricle?
The lungs.
The lungs. Perfect. So if you have an embolism in the lungs, what does that do to the right afterload, right ventricular afterload?
Decreases it.
Increases it. Think of load as weight or resistance. Okay? So if we call it resistance to right ventricular ejection, that's the afterload. What other conditions causes increase right afterload, right ventricular afterload? All different lungs.
Hypertension.
Left-sided pneumo.
Did someone say pulmonary hypertension? Because you left that word out on purpose, right? So pulmonary hypertension does it. What about emphysema?
Emphysema. COPD.
Issues, right? So you have fewer capillaries, more resistance to blood flow. More resistance equals higher afterload to the right heart. And what else might cause it?
Pneumo, left side.
Pneumo. And one subtle one is hyperinflation. If someone's stacking breaths, like in a severe asthmatic or someone who has really hard time getting rid of air, that will cause the chest to become hyperinflated. And that basically really hits the right heart. And the right heart has trouble pumping blood into the lungs. And if you see that, that's where you get things like cor pulmonale, the Kussmaul sign of the JVD, if you will, and causes those problems. You'll blow out your T wave, you start causing AFib. If you notice, a lot of people with atrial fibrillation, if you haven't, you will see, they have a history of some sort of lung disorder. Their lungs create a lot of resistance, the atria stretch, they start popping off extra pacemakers, and they go into AFib. So, academic knowledge for now, but just FYI. Left ventricular afterload is what? What would increase that? The resistance that the left ventricle has to pump against.
Hypertension.
Hypertension again, okay? So you have stiff arteries. Any problems with the aortic valve or mitral stenosis or aortic stenosis? You guys know what stenosis is? It's like a crimp. Okay, so when there's a defect or crimp in the vessel, it's called stenosis or stenotic. And that's where you get the heart is now having a beat against that. And those things, those three things are probably the big ones, increasing left ventricular afterload. So, but if someone doesn't mention the ventricle in particular, preload is venous, and it's what the right heart is dealing with. The heart is a pump as in a whole. And the afterload is arterial, not the left side of the circulatory system, and that's going to be the left ventricle. Coming down here, a few of you, when we had the exercising person with a heart rate of 160, I asked if it was compensatory or pathological. And again, a number of you said that you needed to slow it down. Does anyone still believe that? You guys kind of get the difference? So pathological, like psychopath, means it's diseased. It's abnormal. It's not right. Okay, so if it goes up because it needs to, this is, again, a huge distinction. I use running as an example. But say someone had a high fever or they were basically in shock and the heart rate goes up to like 150 to try to compensate. It's really, really important to keep that in mind. Is it compensating or not? Deal for the breathing. When would you slow breathing down, guys?
Never.
Well, one, we really can't. But two, the only time we're going to try to help breathing, forget the numbers. That's one of the kind of bitches going into JBL and a lot of the medic texts, is they're hooked up on this 12 to 20 heart rate. Use your heads and think, is this ineffective respiration? Okay, so as Mr. Casares, and he's told you guys are learning, your respiratory system is the primary buffer, the fast-acting buffer that you can see. So it's real important to kind of keep that in mind. The only thing you're probably going to do with respirations is increase the volume if they're really shallow or ineffective, or increase the rate. So for your test for next week, where you're going to be reading chapter 15, I've pretty much nixed all those questions that have stupid shit like if they're breathing 22, start assisting them or something dumb like that, because those are just retarded. Those aren't there. But you will have some questions in there, and I'm going through them to make sure they're not retarded questions. All bets are off when you have to test for National Registry, though. The last part. I'm going to read this to you. Patient develops sudden shortness of breath with severe anxiety and lightheadedness. The respiratory rate is 35, full, effective, and unlabored, clear in all fields. Blood pressure is 88/50, heart rate is 140. Pulse ox is 83, and CO2 is 22. The skins are dusky, which kind of means a dark shade of gray-blue, cool and dry. The patient has no significant medical problems. Based on what you've learned, what is the most likely diagnosis? There was a surprising number of respiratory alkalosis answers. There was a disappointing number of anxiety attack or panic attack. Anyone want to step up on?
Dusky could be from some form of hypoxia.
Large PE.
PE, yeah.
A PE. So respiratory alkalosis, or for that matter, acidosis or acidemia, if you don't get a pH reading, you can't tell that. Now, that being said, the patient may be in respiratory or compensatory respiratory alkalosis, but that's not the problem. Any more than the heart rate of 140 is a sinus tachycardia as a diagnosis. Okay, what you can tell is that they are hypotensive, so you look for those big things. Okay, you look for the big things that stand out. You have low blood pressure, we have a low SpO2, and those are not part of panic attacks or anything else. That's a person who's very sick. You have the shitty skin signs. And then if you have full, effective, unlabored breathing, clear in all fields, that pretty much rules out pneumothorax, pneumonia, collapsed lung. The only thing possibly left that can cause that would be an embolism, a new embolism. You guys see that? So just like with EKGs, what are you being taught to look at first in a rhythm?
P wave.
If it's present.
Okay, well, when you evolve, you're going to actually look to see, does it have a narrow or wide complex? Is it too fast, too slow, or normal? Because you can live without a P wave, but you cannot live without R waves. Okay, now you're identifying them. So you're kind of basically looking at what's dangerous or not. As you get experienced, you want to see is the rate super fast, super slow, or normal, and then is it narrow complex or wide complex? Because if it's wide complex, you have to worry it's a ventricular issue. But if it's narrow complex, you don't care if it's a flutter, freaking, I don't know, a narrow complex junctional, whatever. Those will all keep you alive. When it comes to vital signs, you want to get sensitive to, like we're doing the assessments today, what makes a difference? What kills you and what doesn't? So the next one, this got a little tricky, but patient develops sudden start chest pain, worsens on inspiration, and dyspnea. Vital signs are respiratory rate is 24, full, effective, unlabored, and clear in all fields. Blood pressure 128/76, heart rate 110, pulse ox 92, and CO2 is 30. Skins are normal, warm. The patient has no significant medical history. Based on what you've learned, what is a likely diagnosis?
Spontaneous pneumothorax.
Okay. So I heard spontaneous pneumothorax. Let me go back over the respiratory rate. Full, effective, unlabored, or adequate to move in air, clear in all fields. This is, by the way, a good way to report lung sounds because that says everything's kosher, everything's there. Would a pneumothorax lead to clear lung sounds? No pain, nothing, okay? So that's not issue. Is a blood pressure an issue, 128 over 76?
No.
No, the blood pressure, she hasn't decompensated, right, or he. Heart rate's 110. What does that tell you?
It's
Tacky.
Yeah, it's a little tacky, just like the respiratory rate, right? 24, 110. But by themselves, those aren't problems, right? They're just showing you something's up. SpO2 is 92.
A little low.
A little low, especially if you consider what is the respiratory rate?
Respiratory rate? 12 to 16.
Well, the respiratory rate is 24. With
Oh, I thought you meant the
air.
normal.
Yes. So you don't expect to see a pulse ox of 92% with a person who's breathing not only adequately, but even faster than normal. Okay? And the ETCO2 is 30, and that's because they're breathing fast. That's just incidental. Skins are normal, warm, which is consistent with the shock thing. So is it pneumonia? The lung sounds are clear. So if you eliminate bronchitis, we eliminate pneumonia, we eliminate a pneumothorax, we eliminate pulmonary edema, we eliminate other causes of bronchospasm, what are we kind of left with? And it's sudden onset.
Small PE.
Small PE.
Yeah, PE. Now, if you remember your scenarios, again, I realize that you have other classes, but this was that one New Zealand chick who developed it while she was running. The first one was the older black chick who had a critical one who basically passed out in the bathroom and the doctor said he was hypotension and do surgery and everything. Two presentations of the same condition, one's worse than the other because one's decompensated and one was, generic PE. Do you kind of see that? So as I'm looking at the screen, I know it's hard because half of you guys are just zoned out and tired, so it makes me really hate wasting your time. But I can only do what I have to share with you is only going to be as good as you can kind of take it in. So I'm trying to give you some reasons here for understanding this. So when you're looking at problems like this, thinking back to this morning when you were assessing patients, isn't this kind of the same thing you're doing? You're trying to figure out what is sticking out as a problem. And then with a little bit of knowledge of pathophysiology, you're trying to figure out, okay, what can I exclude? So taking those complete vital signs, lung sounds, skin signs, they're all ways to kind of say, oh yeah, this is a possibility. That's probably not. I can forget these guys. It's all helping you get the answers. And of course, the subjective questioning. So at last two, a persistent non-productive cough over the past week and a decreased exercise tolerance. Lung sounds are clear with slight expiratory wheezes. No fever, and all other vital signs are within normal limit. No significant medical history. What do you think is the most likely diagnosis?
Bronchitis.
Bronchitis?
Bronchitis.
Kind of get that? And almost every video, what do they say? Acute bronchitis, it develops basically over a few days, couple weeks. Exercise intolerance. Anyone here ever had bronchitis, by the way?
Yes, sir.
How long does it leave you feeling kind of washed out, like it's hard to work out as hard?
Bronchitis was about 2 weeks and pneumonia was about a month.
Oh, yeah, pneumonia too?
Yeah,
For
twice.
you, I've lucked out of pneumonia. So, yeah, it's kind of one of those things that sometimes it's good to have all these diseases at least once because you recognize them in everyone else. So, again, clear lung sounds and slight wheezes, no fever, everything else is basically okay. The key term is noticed decreased exercise tolerance. And then last one, some of you guys got this one. Feeling sick with a fever, mild shortness of breath, and a cough that's becoming more productive over the past week. Vital signs within normal limits except for a respiratory rate of 22 and an SpO2 of 94. Lung sounds slightly labored, so a little bit of extra work. Fine crackles in the left lower lobes.
Pneumonia.
Pneumonia. Is anyone confused as far as why those answers were there? Okay.
For the small PE one, I might have missed the key
sign that why we got the small PE? Because all I got are just the vital signs on my paper.
Sudden onset.
Was the sudden onset?
Sudden onset,
It was that and the chest pain.
sudden onset, chest pain.
Clear lungs.
Now, and so thanks for asking that. I'm giving you, just like in real life, simple one problem problems, right? I'm not giving you, as I was telling one group, you could have multiple embolisms after each other. Okay, you could have, like, say, the first one, Zavala. She had the sharp pain, a little bit of a drop, and then, bam, she gets a second clot, you know. So it's not trying to put blinders on you. I'm trying to kind of teach you how to distinguish what's important and what's not. And the respiratory rate is the most confused one because, as we all know, no one counts breathing effectively because it's a pain in the ass to do. So until I started, probably my 6th year as a medic, started actually counting respiratory rates for real, I missed a lot of things. That respiratory rate is like your tachycardia of the body. It's very, very subtle and very helpful. Okay.
You're saying that it's difficult to count them?
Yeah, resting breathing is hard to count. If they're labored or deeper or whatever, yeah, you can count them. But I've sat with EMT students practicing vital signs, and I'm like, crap, I can't see them moving. You know, and why do you have all those tricks, putting your hand on their neck or shoulder or whatever? You know, so you get an eye for it, you just have to figure it out or use your CAPNO. And that's going to be your best thing. Is anyone sending me messages? Oh, good. There you got all the guesses on there. How bad is the background noise, folks? Do you
I don't hear anything, sir.
Okay, because I got drills and jackhammers and everything going off in the kitchen.
I heard it.
Got a question? What'd you say, Joanna?
Oh, I said I hear the drills.
Oh, you do you? I was only asked to be polite. I really didn't care. Okay, so let me close that out. Just in case you didn't know, for your quizzes of this week, there are some of the same questions and again. It's very difficult, so I know you guys appreciate the fact that I actually go dig those up and look them up again, but that's okay. Save the applause. I'm doing it just for you to get those out there. Start kidding. The AEIU shit questions, I really liked some of the funny answers. I forget who put a bandage on their brain and some of the other answers. Those are hilarious, but I didn't give you any credit for them, but I do like those. That's the sort of thing that I would do. So start knowing those because those are going to come up because we're doing Ultra LOCs the next 3 weeks. And believe, I was talking to Mr. Leon and Mr. White and Duncan about all these kind of weird cases that we ran across, and that's what you're getting here. So talk back to me, anyone.
In the new patient assessment sheet, so we're not doing AEIU tips anymore. Now it's SHHT.
It's going to be the, yes. Well, you have the AEIU, but the SHHT is, have you guys learned the H's and T's yet? I don't know where you are in cardiology or when you get to that. But Zavala knows what it is, and Fox and Grillo know. That's the kind of differential. Do you remember that, Grillo? You are dying. Are you on, like, let me see your pupils. Oh, they're a freaking pinpoint. All right, so.
No, what was it?
H's and T's.
Oh, yes.
What are those serve you in cardiology and cardiac resuscitation?
They're reversible causes that you want to try to identify when working cardiac arrest and stuff like that.
Do you remember what they are?
Hypovolemia, hypothermia, hyperkalemia, hydrogen ions. What was that? I might be missing one of the H's, but then the T's were like tension pneumo.
Hypoxia.
Oh, hypoxia. Okay. Thrombus for coronary and pulmonary toxicity.
So you get it. The H's and T's, they're meant as the mnemonic to help you remember, but they really don't rhyme with anything. Hydrogen ion for acid, thrombus, meaning a clot in your coronary artery or a clot in your lung. They're just tools. AEIU tips is just one of those tools, and depending on where you see it written, it could be written different ways. The only thing that stays constant is like insulin in epilepsy, I think. So I rewrote this to be more inclusive and follow kind of the AHA deal, because a lot of what we deal with on the H's is hypo and hypers, too much or too littles. So that kind of keeps them in line. And they're all linked to examples of what, why, and how. So yes, that's going to be it. The simple fact is, when we made it with the AEIOU tips, it got even more cumbersome. So also on the OPQRST, we have at the end of time, we have the primary medical history and diagnosis of the same complaint. Jared made his job a lot easier on his patient assessment by asking the patient, have you had this before? Can you guys see the value of that? Okay, that's just almost like one of those common sense things that you would think to ask of anyone. Has this ever happened before? But for some reason in medicine, when we memorize really rigidly, we stop thinking and just go into asking dumb questions. Any more questions on that side there?
Is that assessment, the new assessment sheet? Can we find
it's uploaded? Ooh, thank you. I got to show you that. I'm going to share the screen with you. So that's uploaded under the documents. I'm kind of putting a place for the documents so you can find them, because I have to go like to this long file cabinet thing that you guys can't see. And I'm thinking what would suck for me as a student would be try to hunt down the paper. So at the very top of the stuff, you'll have like that page with documents. So that is done for your benefit. And now let me go to Syllabus. Really? What'd you guys cover this morning that was stuck out in your head, or is the hardest thing?
Heart sounds, actually. Taking heart sounds. That's something I've never known before, so that was cool to learn today.
Yeah, I wanted to ask about apical pulses.
Apical pulses are gold. Apical pulses are gold. Heart sounds, well, about only 30% of physicians and maybe 50% of cardiologists can do them. So don't get yourself too lost in those. Ever since Doppler and ultrasound, echocardiography, that's a dying skill, and it's become an issue in the medical world. It's neat to be aware of them, but I think you'll find it's hard pressed to use those as, bottom line, if you can do it and want to do it, that's fine. But it's a little bit like lab values. You have very limited access to them in the fields, and you would never rely on them completely because it's such a perishable skill. But knowing what they are and why they happen is definitely helpful. Okay, so now I'm going to go to, I'm going to share the screen, see if I can get this right here, and show you something else. Anyone see the CPAP video that I put up? Anyone actually bothered to sit through it? I'll be surprised if you did, but if you did, curious what you got out of it. That was done, okay, share, screen 4. Do you guys see the Canvas page here?
Yes, sir.
Okay, so I'm going to go down here, log in, and as you can see, we have the documents test sheet at the top, the assessment sheet, and then coming over to here, just discovered this, is Studio. You guys see where the cursor is now? Click on Studio, and we have all these videos that I'm starting to upload. And these are kind of resources for you. Some stuff we're going to cover, and it's meant so I can find them because I have like a zillion thousand files, and I start to get like confused between the computers. And then we have, for example, breathing assessment videos, which shows you different types of conditions to look at. These are the ones you kind of found and still adding to really kind of help practice some of those weird patterns. some more training. And then for you guys, for the video assignment homework, when you go on to submissions, when you put your homework, I don't care if you email it to me as a file or you send it and put in submissions. The IT guy said there's no limit on this. So click it in the submissions and put it here and just add your videos. And then feel free to look at any of the other stuff. Last one I'm going to show you. You guys seen these guys before?
No.
Ready to see some amazing experiments? Yes!
Can you hear okay?
We're going to show you how your incredible body works. Just don't try anything you see here at home. Today, the hero of breathing, your diaphragm. What? What is going on? Lucy, meet Dr. Chris. Dr. Chris, meet Lucy. Tom, I know who Lucy is. We've already met. Have you? Yes. Hi, Lucy.
Hi, Chris.
I saw her on The Voice, and it was me who asked her to come in. Was it? Yes. I thought Lucy could help us demonstrate the power of the diaphragm. All right. Now, Lucy, could you give us another long note, please? Now, Lucy and other opera singers can hold a note this long because she's trained a special muscle, one which we all have, called the diaphragm. Now, your diaphragm sits there at the bottom of your rib cage. Thank you. Let's find out what the diaphragm looks like and how it works. Lucy?
I'm going to show you.
Thanks, Lucy. Your diaphragm is the main muscle you use when you breathe, which is something we all do all the time. Now, to show you what a diaphragm looks like, we've got a real one from a pig. Now, this is the pig's voice box. This is the trachea, or the windpipe. These bits are the lungs, and then underneath the lungs, in a big muscular sheet, that is the diaphragm. You breathe in and out about 20 to 30,000 times a day. And it's this, the diaphragm, that makes it all happen. So after your heart, it's the most important muscle in your body because it allows you to breathe. Now take a breath. Most people have no idea why the air moves into their lungs. We're going to show you. Take this away, Chris. I've got a model. Now, the big bottle is your rib cage. And these things inside represent your lungs. Son, those aren't lungs, those are my party balloons. We're using them for a very important scientific demonstration. Okay, well, I suppose if it's in the service of science. Good. And this, at the bottom, is your diaphragm. Now, we tend to think that breathing is all about the lungs, but the diaphragm is the unsung hero of breathing. It's what makes it all happen, and that's why the diaphragm is such an important muscle. Now, when you breathe in, the diaphragm pulls downwards. This lowers the pressure inside this chest cavity. This creates extra space, a vacuum, and air has no option but to rush in through your mouth and into your lungs to fill this space.
Okay, you guys see that there? These amazing graphics right there. Are y'all on? What's this vein right there?
Your inferior vena cava.
And what's this one here?
Superior.
And these ones?
Pulmonary artery.
Subclavian.
Subclavian.
Okay, but that's not the real magic. The real magic is I managed to get this on here to try to show that you have this pump, like you've seen in the video, and how it creates that vacuum and pulls the lungs open. And by the same token, as this pushes down, it pushes blood back to the heart, improving preload. These are the only guys online I could find who showed an actual demonstration of negative pressure pulmonary inflation. And I really did.
And then you breathe out again. Your lungs really are a bit like these balloons. They have no muscles at all. They're just like bags, really, and they don't do anything without the diaphragm. It's pretty amazing. And to show you what your diaphragm looks like in action inside your body, here's mine. These big black areas are my lungs, or party balloons. The pulsating bit in the middle is my heart, and down at the bottom, this is my diaphragm. Now, what you can see is My diaphragm here is contracted, and now it's relaxing. And as it relaxes, it rises up and forces air out of my lungs. As you then breathe in, the diaphragm contracts again, and just like the pink balloons, the lungs fill with air. That is incredible. So we've shown you that your diaphragm is the real hero of...
So the lungs are the ones that are pushing the diaphragm down, though, right?
No. The lungs are spongy tissue. If you put the lungs, did you see the pig lungs? The lungs are just a blob in the diaphragm. So if you need to see that again, and I encourage you to do it, because once you get it in your head, you'll be set. But did you see how the diaphragm pulling down helped get the...
Right, it inflated them.
Right. It doesn't directly inflate them. What it does is it creates that vacuum. Let's see if it comes in again. Now, when you breathe in, the diaphragm pulls downwards. This lowers the pressure inside this chest cavity. This creates extra space. You see this right here, Martin? So
right. It creates
the
that
diaphragm's up. These guys collapse. If he had capped off the top here, like obstructed the mouth, there would have been no air to pull in, so it couldn't have expanded the lungs. Well, with the mouth open, as this pulls down, it sucks air in by creating a partial or negative pressure here.
So the negative pressure I get, but what again is exactly pulling that diaphragm down?
The diaphragm is a muscle shaped like, can you see my hands?
Yeah.
Okay, so think about fibers of the muscles. Okay, your muscles can only contract actively, they relax. So if my muscle shortens, okay, it has to flatten out. Okay, so as my diaphragm contracts, it becomes flatter and it creates that pull. As it relaxes, it goes back into the dome. So you work that out. If you want to picture these as muscle fibers, they're all the way out here. As it contracts, it shortens. And just like the shortest distance between 2 points is a straight line, now it's a long muscle. Now it's a short muscle. And that's part of it. And of course, then you could expand it the other way. So if that proves to be still a little difficult to get, hit me up offline, and we can certainly do that. So this is, again, showing you the videos. And the last little announcement before I take a quick break is to show the homework. If you haven't seen it. And what we'll have you be doing is doing short videos and see how that works for you. So I'd like to kind of get your feedback on this. As far as the idea of, instead of doing writing assignments, is basically doing kind of a video like you're teaching a stroke assessment or what have you. So you're kind of like, instead of having to write, you are still covering the material, but presenting it and describing it, sort of like when we're on class. Describe this, describe that.
So I take a video of yourself, are you saying?
Or have someone take a video of you. Now, I'm not...
Take a whiteboard and explain it and stuff like that?
It doesn't, yeah. For example, on the CVA assessment with the 6 steps that are in the stroke assessment that we have in the assessment sheet, you would simply, just like I demonstrated to you in class, hey, this is what I'm checking. Checking for facial symmetry, have them smile with a grin, and show what a normal one is. And then, for example, okay, this would be abnormal. Then you do your grips. I'm checking for motor strength, okay? Upper arm motor strength. Pushes and pulls on the feet, same thing. Palms up, eyes closed so we have proprioception, and so on. It doesn't have to be pretty, but it basically, you go through the steps and you're going to describe it.
I think that's awesome.
Yeah, that is awesome. Do we have to? Are we wearing our uniform like in the video?
Honestly, as long as you're not X-rated, I couldn't give a damn. I just want you to show that you kind of at least know it and memorized it long enough to say it for 5 minutes. Okay. Again, the whole point is not to make work. This is a kind of struggle as to get space in your head. So
one of the easiest ways to learn things is to teach it. And so if you have to kind of teach it, then we can see how this works for you. And then recording it, you've created your own little study guide. Now, the downside is I have to watch all your damn videos. But I have to argue that it may be easier to watch your videos and watch some of your spelling. Okay. Honestly, I've like committed harakiri 3 or 4 times already watching that spelling. So we'll see how this works. So if you don't learn anything out of this, it's wasted time. And this is going to be my attempt, and that's taken. I was talking to TJ. In Europe and some of the classical schools, they don't do written test or multiple choice. You actually do kind of like answer and describe stuff because there's no way you can kind of bullshit your way through it. And I figured you would not mind having one less thing to write. So
I think that's an awesome idea.
Canvas or
I think it's a great idea.
So the instructions are in the lesson, but I have it there for the Bell's palsy, create your own teaching video. And the only thing you have to remember is if you upload it to Studio, which is, again, all the way on that left side, or email it to me. I don't really care, just a short video. And if you do it as a link to your own YouTube page, that's fine with me too. What I want to see is that you're doing it. Now, this is not what I mean by doing it. Operating and ducting for that. Now, if you have good eyesight and you're watching the wall across the room, I really don't care because at least you have to put some effort to write it down on the wall. But clearly make it some sort of attempt at a demonstration, okay? And we'll see how this works and let me know because this could be something new. I don't know of anyone else doing this right now. But with the video format, it makes sense since you guys are all busy filming yourselves doing porn parties and other stupid shit like swallowing Tide Pods. Might as well add education to it while we're at it. So, but never fear, you have an optional test bank. And because next week we're doing the endotracheal tube stuff, you've got your selected reading. I did not give you the whole chapter because some of it's dumb. And I refuse to put it out there as educational material. But you do have to know some of the stuff. A lot of it will be review and your endotracheal tubes and your King Airway. But OPA, NPA crap, I want to show you that in person, and airway positioning and stuff, we'll do that in person. So, oh crap, this is all recorded. Now what? So, any questions at this point?
Mr. Ritchie?
Yes.
For the optional test bank, I see that it's worth 198 points. Is that, would that affect our grade or?
Oh, 198 points? Oh, it sure as hell would.
Okay. I thought it was like, okay, because it says optional, so.
Oh, no, that's not. I have to edit that right here. I got a little command function right here called edit. And now it's not optional.
Okay.
Magic. However, the other number that will be adopted on that is I'm not giving you 210 questions. And it's really actually a pain. I started working on it last night, but so many of the questions are really stupid that I have to edit them and then I have to delete the ones I don't like. So it'll probably be around 30 questions and try to make them relevant. But a lot of it's National Registry, so it includes criking people, RSIing people, paralytics, and junk like that. And then really dumb stuff, like if someone's lying on their back and they start to throw up, what do?
Lateral recumbent.
Get on their side. But their option is prepare suction and suction them. That's why I think the people at National Registry are brain dead because that happened to them and they damaged something in their heads. So those are really dumb, and I can get rid of those.
And then one more thing, sorry. The Chapter 15 test, is it due by the 23rd, or are we doing that in class?
It'll be by the 23rd. And that's going to confer. That's going to basically reinforce your reading. So on your reading, I put up some special stuff here. I put your pages and the tables to know. And you guys can still see that, right?
Yeah, we can see that.
Okay. So I'm not going to bust your balls on like Lemon and Malampati. I'll describe them to you, but these are kind of lame because that's what you do when you have an elective airway. But the Cormac-Lehane, which is a sign when you're visualizing someone's vocal cords or trying to with a laryngoscope, that actually is a great view that you have to kind of describe in your test. Malampati doesn't work because you have to do that when a patient's conscious. You ever go to surgery and the doc says, show your mouth, he's checking your Malampati. And Lemon is basically the shape of your head, stiffness of your neck, how many chins you have, all that stuff. But guess what? If you have to intubate someone in the field, in this county, in this state, you don't have a choice. Doesn't care if they have no neck, big teeth, small mouth, bad mentum. It's not like you could say, no, we're not intubating. But if you're doing elective intubation, the reason we did that on an aircraft is we would have RSI options and then multiple airway options all the way down to surgical airway. And in a hospital, they have the same thing. As dumb paramedics, we don't. So I don't think those are important, but Mr. Casares will run you through those. And then the last part here, I wanted this printed because you see apneic oxygenation. This is pretty fascinating, and it's basically I can keep someone alive with a nasal cannula at 15 liters of oxygen for an hour while they're not breathing. Apneic. Published papers of people sitting there in the ER like this here. And they have a special high flow nasal cannula. You have to pretty much glue it onto the spigot. And it pushes oxygen and it diffuses through that dead space you're told so many bad things about and keeps you alive. After an ER nurse taught me about this, I stopped bagging patients pre-intubation. I just put a mask on them and run the O2. I document they were bagged, but I don't. So you don't want yourself in trouble, remember.
I was going to ask, are we still going to be tested on bagging, though? Or when it comes to innovation?
I want you to know how to bag, because if you do know how to bag, and you will have to bag, that's just the reality of it, doing it well. So whether it's an actual test, I'm not really worried about that. I've kind of showed you the important stuff, so I'm going to trust that you kind of know that. But things like putting in an MPA right and stuff like that, I definitely want to show you. And but as far as an actual formal test on that, I don't think I'm going to run that through. We got enough crap to do already. So what I'd like to do now, any questions, is give you a few minutes. And if you want to stay here, if you guys got to do whatever, Grillo, wake up, do what you got to do for a few, take a break.
You mentioned Crike. Are we still going to learn that not till winter, or is that this semester?
No, this semester we have to cover oral tracheal intubation, King airway, nasal tracheal intubation, Crike, and I can't remember if we're doing pediatric or not. It's almost the same thing. I have to look at syllabus. Mr. Fontaine never got back to me, and it's kind of weird because we're teaching all these skills because we're kind of meeting the National Registry thing. Oh, CPAP. And in other states, you could still do those skills. California's pretty freaking lame when it comes to EMS, but our training's kind of weak too. So you really want to be well trained for you doing those other airways.
Mr. Ritchie.
Yeah.
So we're moving into intubation now for this lecture.
No, this intubate, the homework you have is going over the intubation. Like that's why it's chapter 15 reading. That's got to be hands-on. So next week it's going to be CPAP and ET tube and King. So just basically skill stuff.
Okay. What are we lecturing about today?
Lecturing about today, it's going to be thank you, I got to get the sheet here. It's going to be about this is the first day of the alternate LOC stuff.
Okay. Copy that.
Mr. Ritchie, a question regarding the videos.
Yes.
Can we team up with our classmates to do it, or does this have to be like an individual thing where we make a separate video for each?
So the question is, can you team up? And who was asking? Because I can't see now.
Me, Hector.
Let me put stop share so I'm actually looking at you now. Okay, so say Hector, you team up with Jarrett, and Jarrett films you doing an assessment of a mannequin or your mom or someone else on a stroke assessment. And then that's you. You're yakking and doing your piece, that's your video. But then Jarrett needs to do the same thing. So teaming up, sure, that's what I would do. As you're watching him, you're learning. As he's watching you, you're learning. But you have to actually explain or demonstrate the skill. It can't be like you're like that, talking back and forth and describing it. And that's your question?
Yes, sir. Thank you.
Okay. Are we back to looking at each other or not?
No,
sir.
I can't see anything. Oh, there you go.
Okay, good. Oh, I guess I can't minimize it. Faster.
Are we taking a break right now, sir? Or are we?
That's what I said. Take a break. Yes.
Okay.
Sir, so when you were explaining the whole lungs thing with your hands, I don't know why I couldn't see it. Can you show me again? Sorry. That's something that I struggled with last time, and I kind of get it, but I know I saw a comment saying that your example really did help.
Tell me what it was you're asking about again in terms of what was it about the video with the two dorky doctors?
Oh, the lungs, regarding the diaphragm.
Yeah, okay. Oh, shortening of the diaphragm.
Yeah, because you were explaining it, but my screen was frozen, so I was only able to hear it. And then I saw comments saying like, wow, this really did help. Okay. And I was like, I can't see.
So your diaphragm is shaped like a bell. In a healthy person, believe it or not, we are not healthy the way we breathe. But can you see this?
Uh-huh.
And I can't really show it, but if my diaphragm was here, remember I showed you rib cage? So if you find your xiphoid process, it's up here. Can you see that? So here's your xiphoid process, right?
Yes.
And then if I follow my ribs down, they go down and back. And your diaphragm follows just like that.
Right.
You can actually feel your diaphragm if you stick your fingers under your ribs. You feel your diaphragm there, okay? If you do a manual therapy, you'll actually find it.
Uh-huh.
Now, have you ever belly breathed before? Like a yogi, push your belly out when you take a breath? Try doing that. Inhale and inhale down to your belly button. And don't let your chest move. Don't let your chest move and inhale. And make yourself fat doing it. Did you do that?
Yeah.
Okay. What pushed your belly out? Your diaphragm.
That right here.
Shortened and pushed down. And then your guts and stomach and everything else went right down because your diaphragm shoved it down. And that pushed your abdomen out.
What the heck?
Magic. That's called diaphragmatic breathing.
Uh-huh.
That's actually fundamental to your core strength and support.
What?
Okay. So if you think about, you guys have heard about core, and people, I would imagine, think of core as like a six-pack, which is pretty common, and doing a bunch of crunches and abs and planks and crap like that. Well, the number one function of your core is to stabilize your spine because your spinal cord runs through it. And if you think about it, have you ever like gotten so tired, like running in track or something, that you had to bend over to breathe? You're just like hands on your knees or just flop down on the ground.
Yeah.
Okay. And you ever wonder why you feel so tired that you don't want to hold yourself up anymore? Well, it's because your diaphragm is exhausted, and without pressure, you don't hold your torso up very well. It's like take a deep breath and make yourself tall with that breath. That's all pressurization. Your respiratory system is your central core musculature.
Okay.
So if you get tired, you slouch, and then you go to tripod, and that's basically so you can rest your diaphragm, and instead of kind of pressurizing your torso to keep you upright, you can focus on just breathing.
Got it. All right, that makes so much more sense.
So anyways, as far as relative to the lungs expanding and so forth, it's that depressing of the diaphragm. And if you want to see it depress, you watch your belly bulge out when you push down, and you can do that. That's kind of funny. Everyone's looking down the belly. And if you get really good, you can activate just one side of your diaphragm in front and back. And that's how I kind of play with lung sounds when I fake pee a patient. I can shut down one side now.
That's kind of cool.
You're learning it a lot earlier than I am. I didn't know this crap. But if you ever notice, when you get punched in the solar plexus, what does it do to you? You double over. Why? Because it paralyzes your diaphragm. You can't breathe.
Right.
It's a solar plexus, and it paralyzes your diaphragm, and your vagus nerve runs through it, and that's why you want to throw up, can't breathe, suffocating all at once, and praying that whoever hit you like that isn't going to hit you again while you're totally helpless.
I always assumed it was a fragile muscle.
Oh, it is fragile in us. When they measure, when they do CT scans of older people, especially people with COPD and emphysema, they do always breathe like this. This elevated chest wall breathing, the diaphragm doesn't move. Well, the rate of back injury skyrockets with that because you lose spinal stability. And they start breathing faster and more shallowly. So respiratory dysfunction is the first thing that happens when you don't know how to breathe diaphragmatically. There's a lot to it. I was actually going to put a link up, and I think I will now, because the whole 12 to 20 breaths a minute is actually fairly pathological. We're designed to breathe about 6 to 8 times a minute max. But when we don't do it well, we start breathing faster and faster and faster, shallower and shallower and shallower. And effectively, we wind up increasing our dead space and reducing our efficiency. So when I was competing for nationals in the 90s, late 80s, lieutenant who I used to spar with all the time, he says, you need to learn how to breathe. And I was like, you're stupid. Of course I know how to breathe. Yeah, I didn't know. I learned all that crap later.
Mr. Ritchie.
Yeah.
You know the life packs?
Huh?
You know the life packs, the monitors?
Yep.
Do you know you can turn it down to like 1 joule?
Uh-huh.
You think we can shock ourselves with it?
You can, except, well, yeah, you could. But if you get caught doing it, I'm not going to rat you out, but if you get caught by Mr. Fontaine, he finds out, you can drop from the program.
Gotcha.
Okay.
So how high do you think we can go in that?
You can go up to 360.
Let's do it.
You didn't say walk away from it. Okay. So you can go climb up a freaking power pole and grab onto a 50,000 volt line too. But maybe the last thing you do. But I'm going to show you kind of a pacing trick next week if I can, when you have your monitors, because there's some stuff you should know about monitors. So, and any other goofy questions? Do you work on an ALS unit?
Me?
Yeah.
No.
Oh, well, you should get a job working for McAMR. Then you can go play with the monitor while your partner's inside and see what happens. So that's how I experiment with stuff. Okay, so going to go down to, this was poorly thought out. So, shit. I was planning on doing this sort of thing in class. So let me start just off the top and start off with altered level of consciousness. And what's our first one? We have, let me back up a second. Altered level of consciousness, GCS of 3, 214. Okay, in terms of a chief complaint, that's one of the hardest ones and the most complex ones to get. Because frankly, anything will make you altered eventually. If you think about it, you stop breathing, you'll become altered. If your glucose goes too high, too low, you'll become altered. If your blood pressure drops too low or goes too high, you'll be altered. You traumatize anyway, you'll be altered. So when you find someone who's altered, especially if they're unresponsive, that's the most complex finding. So I'm going to start with the first one, which is going to be just kind of clearing stuff with the CVA assessment and bounce this back and forth because some of this stuff you know. So looking at the CVA assessment, starting with A, let's kind of go with the A for alcohol and give me an example. I know this is really obvious. This is an easy one, but we'll keep going.
Long Island iced teas.
Okay. And what does the alcohol do to you? And
Makes you a really good dancer.
So that's what you call a seizure on your feet, huh? So, okay. So you're a good dancer. Then when you stop being a good dancer and you start being a dork, what happens after that?
You are dehydrated on the cellular level.
Okay, well, dehydration on the cellular level is sort of like saying I'm hypoxic on the oxygen level. Duh, of course it's going to be on the cells. So we're not talking about that. When you get drunk and you're now not just kind of like tipsy or doozy, but actually drunk, what's the most drunk you've ever seen someone? Think about someone who is...
Like falling over?
Okay, falling over, but can they talk to you?
No.
Very badly.
If they're a good drinker, yeah.
They might be slurring their words or whatever, and that's a deal. What about the next step of drunkenness?
Passed out.
Okay, passed out.
Blacked out, throwing up.
All right. Now, a little known fact, and this is done for your welfare. If you just drink, you know, and you're not taking like 50 shots at a time, you will pretty much pass out before you kill yourself. You'll be, see, Grillo's nodding his head. So if you just drink, you'll pass out. It is kind of a safety mechanism. It goes straight from your stomach to your liver. And of course, women, God bless them, were missing one of the enzymes for processing alcohol, so they tend to get drunk more easily. Okay, not always you can habituate. But if you say got in a drinking bet and you're someone like me who loses every bet and winds up having to take like 10 shots in a row, now you can intoxicate yourself to a point of fatality because you've drunk alcohol so fast that if you don't throw it up, it gets absorbed like a massive bolus and you can go into respiratory depression and basically go into a coma. If it's just for the coma, you'd probably be okay, but if you fall asleep on your back or go into a coma on your back and then you reflexively puke, that's when you aspirate and die. All right, so that's kind of the no-brainer part. Delirium tremens, withdrawal from alcohol. Everyone heard of that? Okay, what is the concern there? Say you got to call to the jail for someone to pick up off the street.
Seizures, airway.
Okay, so let's start with the seizures. Seizures, convulsions, tonic activity. What's a tonic seizure, by the way?
That's just one that stops. Is that what it is?
Involves all your limbs.
Full body.
Grillo?
Is that just when you kind of just stare off? Or that's focal motor?
That's an absent seizure, or whatever the terminology. A tonic phase is when you're just stiff. Think of it as posturing. Okay, you lock out, whether it's decorticate, decerebrate, you're just really stiff. Clonic is when you're doing the high speed 150 hertz vibration, okay? So tonic clonic seizure means they started stiff, like in a classic epileptic seizure when they drop or fall, stiff as a board, then they start actually convulsing. So clonic is like the convulsive seizure. Tonic is just a rigid posturing point, and that can precede everything. So that's our AA. Then we want to go to the next A. Anyone got the sheet in front of them? I can open up so many stupid sheets at once here.
The airway.
Okay, airway. This wasn't originally on there, but it's actually a big issue, and every medic class usually catch someone. So you get up on scene, and a woman tells you that a guy just walked out of the house and keeled over onto the ground, unconscious, unresponsive. She'd just been talking to him 5 minutes before. When you go up on that person, what's the first thing you're going to do? In real life, now that you're not primed for airway, but what's the first thing that comes to mind?
Check his airway.
Check his pulse, okay. Now, how do you check his airway? Back to that first day of class.
You try to talk to him, try to arouse him.
Unconscious, unarousable.
Try to listen for breathing and look for, I don't know.
Hear any breathing? Is that
Just try to see if you feel any air moving, maybe.
you don't feel any air moving?
Visualize his airway.
Okay, visualize anyone's airway. Could someone show, who said that, by the way?
Right answer.
I can't see who's where. Is that you, Adam? John?
Yes, sir.
Okay. Where are you again? Sorry. Speak again.
Right here, sir.
Oh, perfect. Okay. Clap. Ah. Hold on. Let me help you a second. See my vocal cords?
Not really.
So you visualized what?
Stomach.
You saw my uvula, and you might have seen the remains of my tonsils, and maybe some freaking leftover cheese, but you didn't see any airway. Okay, you saw my pharynx. So that whole looking in there may be good, but it doesn't clear the airway. Someone stuffed a sock down my mouth and you saw the tail end sticking out, maybe you'll see that. Okay? But most people who are conscious and get something stuck out, you can grab your own crap out of your mouth, right? So how do you check the airway?
Can you listen?
I already went through
Thank you.
no movement of air.
Sit down and open it.
Section.
You gotta open it up.
Jaw thrust.
Grab the jaw. Grab the jaw
thrust.
with both hands.
And you did the jaw thrust with both hands and you opened it up and it's still no breathing.
You can't visualize.
Start CPR.
Well, that's one.
Put in
solution.
an OPA,
What?
OPA or MPA.
Would you stop squeaking?
Sorry.
Speak. I'm here. I got my jaw thrust. I'm like, I'm perfect now. How do you confirm my airway is open?
Look at your stomach.
Bag them? Oh.
Bag them, make sure no resistance.
How about that? Is that
Lung
your
sounds?
question?
Yes, sir.
You test the airway. If you don't push air into the airway and then confirm it with either capnograph or lung sounds as you're doing it, you cannot confirm the airway is open.
Job, Eric.
You guys remember that from the August little in-service class? You have to do that, okay? If you find another way to do it, let me know, and I will tell everyone in the world about you. But short of carrying a laryngoscope and a bronchoscope, or a camera-guided ET tube, or bougie, or something like that, you're not going to know if the airway is open until you test it. If the person's not breathing, if they're apneic, because if the obstruction is above my vocal cords, where the hell is my code here, anyways? Must be in the other room. If the obstruction is above my vocal cords, do you think it's just going to sit there? I would have coughed it out, hacked it out, spit it out. And if for some reason it was there because I was super drunk or something and it just kind of stuck there, then you could see that. But if I've sucked something down through my vocal cords, you're not going to see it. And you won't know it. And if you just bag the airway without checking lung sounds, you can push air into the stomach just fine. So you need to be checking lung sounds. And obviously, if you're in an ALS unit, doing capnography to be kind of sure. And there you test the airway. And if you can't bag them without resistance, then you have to consider obstructed airway. So who said start CPR? Was that Robert?
Yes, sir.
Does anyone have any questions about establishing the airway is open by just looking in your hole? It's an impossibility. You can't do it.
Still,
I have a question.
Huh?
So I have a question.
Yes.
So why are we starting CPR before if we don't even know if the airway's patent? Because everybody's like, oh, get on compressions.
Well,
and they teach that too to people.
Okay, so let's look at it as if you start chest compressions and the airway was not obstructed and they weren't breathing, and presumably if they weren't breathing for any length of time, they're dead. Will it do any harm?
Well, I mean, you can't. They're already dead.
Exactly. If they have an obstructed airway and you can't confirm it, and they're effectively dead for all that you know, what is the first aid treatment for an obstructed airway? CPR.
Yeah.
Well, Heimlich maneuver.
Well, if they're supine on the ground, you probably won't be doing it. And yeah, you could try an abdominal thrust, but the chest compression does as much good. Remember Menacer and squeezing that guy's chest? It does as much good to eject air out of the trachea. So it's kind of one of those things where there's no downside. If the person's unresponsive, apneic and pulseless, there's only upsides to doing chest compressions. So it's like, I don't know what to do, start chest compressions, go to CPR Island. Make sense? If it was an obstructed airway and you clear it and they aren't brain dead or jacked up, they'll wake up. And in that case, you solve the problem too. You guys good on that? So kind of one of those things in the field of EMS, you want to have certain decisions like in your head that are ready to go, that you don't have to really think about it too hard. Stopping seizures is one of them, and chest compressions for someone who's unresponsive, and apneic and pulseless is one of the other ones. And defibrillating VFib and VTAC is another one. So, yes, who's the other question?
Just real quick on the same topic, because like he was saying, it's once we confirm pulseless and they're not breathing, we're immediately going to go to compressions. But I do recall you gave me a scenario where I didn't check apical pulses.
Uh-huh.
And I killed the guy. Because,
Okay, so you have to get dirty on me. All right, good. So this is a low blow, but I would expect nothing but
No. I'm just saying. The point of the question is because we don't check apical very often. We just check carotid and radial, and then we completely miss the apical.
That is a huge shortcoming and a topic for debate. So everyone knows what apical pulses are, right? It's something I've told you about, and sometimes I feel like a broken record talking about it. But you can have, like, the PEA thing. It's a garbage term. It doesn't really tell you much except you can't get a pulse on someone. But you can have a PEA and be perfectly alive. So can anyone think of a situation where that's possible? And that's especially for the medic students who've had this before. A VAD.
Yeah.
Okay. You have a VAD, a ventricular assist device, basically an artificial pump in your heart. What is the rhythm going to show, especially for an LVAD? It's going to show a sinus rhythm. You have to have atrial return, right heart function, for an LVAD to work. But you won't have a pulse. You guys get that? Because it's like a screw. It doesn't make a pulse. And if you don't remember, the first time we had one of those was out of Station 26, which is in East Hemet, and they had a VAD patient who was unresponsive, and they did chest compressions all the way down to, not Tri-City, but not UCSD, but the one that's down there when the 15 and the 163 split. A long damn way to do CPR.
Sharp Memorial.
Huh?
I think you're thinking of Sharp Memorial.
Yes. Okay. And why? Because he had a PEA. No one listened to his chest. No one checked other signs of life. Okay. So listening for apical pulse, like with a VAD, is pretty simple because you're listening to an engine. All right. And if you have a person who's hypotensive, say due to hypothermia, do you guys remember that call that I mentioned, talked about? Okay.
Yes, I believe it was the scenario we got with Instructor Patchen. It was a guy who was homeless, and he'd been out in the cold because I remember it was cold that day and it was raining, and we couldn't figure out what was wrong with him, and no one got an apical pulse. And I remember Kara was mad because she's like, well, what do you mean? What do you mean there's heart sounds but no pulse?
Yeah, that's where my question's coming from.
So actually that was taken off because at 77, I have an incident report that I have on my computer here that I saved. And it was a patient who was a woman. Her neighbor called, or her daughter called from out of state, said she wasn't answering the phone. She was lying down on her patio. She had a GCS of 3. She was unresponsive, on her back, and it was like 45 degrees outside. She'd been out all night. And we got up on scene, and she had no pulses. I listened to her chest immediately, and I heard a heartbeat. Doop, 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 beating about 55 a minute. The second indicator of life was she was breathing, albeit slowly, about 12 times, 10 times a minute, and her CO2 level was at 10 with nasal capnol. Glucose is okay, BP was unobtainable, and her temperature was 79 on my thermometer. It was 76 in Inland Valleys. So what do you do with that? Is she alive or dead?
She's alive.
She's alive.
How do you know she's alive?
Well, you can't confirm her dead until she's warm and alive.
Well, aside from that, fair enough. But when you have to make a decision doing chest compressions or not, what's your decision point?
Slowly warmer.
She still had a heartbeat, so you'd want to do like warming procedures, warming measures.
This is where things get a little sticky, and I can't tell you anything. I can't teach you how to think. I can only point you to AHA. The decision point was they try to say don't count too much in apical pulses because you may get confused or whatever. What cinched it was she was breathing. Because where does your breathing control come from? The brain stem. And if she's not having a working brain, then she wouldn't be breathing. But her CO2 was super, super low. That's like way low. That's like termination of efforts in the field. How do you explain that? What was her body temperature again?
76.
And
or
why is our
79.
body temperature 98 or so degrees? So our metabolism can hum along at an ideal rate. If our temperature went up, our CO2 production would go up. If our temperature goes down, our CO2 production goes down. When our temperature goes way down, the CO2 production goes way down. But it's not written in any of the standard resuscitation books. You have to kind of dig through the leaves, the weeds for that. So my order at the scene was just to fly her out, called Inland Valley. I said to my guys, do not disturb her at all. We'll just do a nice, quiet little IV access and move her as gently as possible and get her ready to fly out. Called Inland Valley. And if I had just called the MICN and says, oh, yeah, I have a patient, 68-year-old female, unresponsive, breathing 12 times a minute, and a PEA, because technically she's a PEA, what do you think the nurse's next question is going to be? Well, why aren't you doing CPR? So I said, the patient's technically in a PEA, but I have good, solid apical heart sounds. She's a sinus Brady. She is breathing spontaneously, so I know her brainstem is perfused. And she's freaking cold. That's why she's so low. We're going to keep her as still as possible and let you guys deal with rewarming. And they're like, okay. Well, as soon as Mercier flew her down, they started chest compressions on her. So the fuck asses did not tell her, and guess what she went into? AFib. And that's where she stayed until she was dead. That call really pisses me off. Now, being savvy to the world of getting your ass reamed for not being like everyone else, I made sure I went to HA's website, checked it out, looked up their extreme cold weather resuscitation, and guess what they say? Use your brains. Look for other signs of life. You cannot rely on a pulse when they're super cold. So I'm not trying to say that like I'm some sort of genius. I'm hoping what it shows is if you think of why stuff happens in the body, then you can kind of put two and two together and use reason. You know, that's the best I could tell you. Now, had I done chest compression, she would have gone into VFib right then. No one would have ever known different. She would have died. I would have still been a hero done. And we'd have to restock our drug box a lot more. So what do you guys think about that story?
It's interesting. For sure.
The importance of apical pulses to confirm whether or not someone's actually dead.
Just, yeah, importance of, to me, using your head. And we had a call at the prison, the same guy. The guy banged up on his head. I was at the head. I did the intubation. And we had a spike in CO2 with the CPR. So he stopped. I put my stethoscope on the chest. I heard the heart beating. Okay. Oh, we're good. And they're like, well, we can't feel pulses. Well, it takes a while for pulses to come back because for pulses to happen, your vessels have to constrict again. They have to be tight enough to create a resistance. And I don't want to create an argument there with the other medic. He doesn't work for us anymore at CAL FIRE, but I said, hey, he's got a CO2 spike. He's got apical pulses. I'm good. No, we got to do chest compressions because the CO2 is too high. I don't know what the fuck he's doing there. So anyways, that's the sort of shit you do. So it's just another tool. It's not the end of the world. But the other thing is this. If you're coming home, how many of you guys have a stethoscope in your car? Any dorks here? I got like a full kit, right? All right. The other thing a stethoscope is, it's your best EKG for counting rate. When you listen, I've been on a BLS engine where I was on a state engine, for example, so I don't have my medic shit, but I still carry my stethoscope and get on a call and listen to the chest, and I immediately hear, oh, dink, 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 dink. But how fast is that? 160, 170? Meanwhile, the other guy's taking the pulse and is only feeling every second or third beat. It says, oh, it's got about a 60 weak and irregular. Apical pulse, dead accurate. You cannot get those sounds without the heartbeat. The valve closure is doing it. So when I go on a scene as a medic, because someone's carrying a monitor, you have a stethoscope right with you. I can listen very quickly, especially if the patient's complaining of palpitations or something sketchy, and I can immediately get a heart rate and tell is it super fast, super slow, or normal range, long before someone can unpack the monitor, hook up the electrodes, and do all that crap. It gets me ahead of the game. So it's a tool. That's all it is, guys.
Should we be utilizing it in every one of our mega code, or pretty much every scenario now that we know?
I would try just to get it a habit. Plus, it's around your ears. So if you're listening to lung sounds, how much of an extra step does it take to listen here for a couple seconds? It doesn't take much. It's more to, the reason it's on the sheet is to get you to think about it. Because what do we do on every call now? Everyone gets a pulse ox reading, right? Would you think of running a stub code call without taking a pulse and a BP? When was the last hypotensive asystolic stub toe call did you run? Well, we still take blood pressures and pulse oxes and heart rates, right? Because you're so used to it. So the idea here is if you get used to doing it, then you don't miss stuff. Just like glucoses. So it's going to be up to you at some point. I can't say to use it all the time, but the more tools you have, the better you are able to scope out the problem in certain circumstances. So we got the alcohol part, the DTs. If you run into a seizure and the seizure doesn't stop before you get there, stop the seizure. Simple answer. You got a benzo, stop the seizure. You never go wrong. Promise you're never going to give someone 2.5 milligrams of Versed and they wake up dead. You'll stop the seizure and chances are they'll wake up sober or more awake or at least breathing better. Bell's palsy. That's what I was going. There is a video for you guys on that, and you'll describe it, but who knows anything about Bell's palsy? Brooke Barker.
I don't know too much about it, but I think it's the one where like you test them by asking them to raise their eyebrows.
That's better than I would have done. Okay, Escalona? You're listening to music down there, aren't you? What are you listening to?
Who, me?
Yeah.
Nothing?
Anyone hear anything besides me?
Your drills.
Bell's palsy. I bring it up because this is an easy one to screw up with a stroke.
Is it an infection of like one of your cranial nerves, and then
yeah, and you lose you have muscle weakness on the side of the face, which causes like facial droopage from a viral infection.
I like that, droopage. Yeah, they don't know exactly what caused it. Could be trauma to the facial nerve, and I don't care about the names of the facial nerves. It's not important. But the simple fact is it could throw you off because when you see it, it's like the face drops. The difference between Bell's palsy in a nutshell is, and this could make you like really kind of cool on scene if that's what you're into, is if you have a stroke with facial droop, it's facial droop below the eyebrow. Okay? You still can wrinkle your brows. In Bell's palsy, it hits the nerves going both ways. So it basically flattens out to you, basically get a smooth forehead as well. And yeah, they can't close their eye. And they mentioned something about the labial fold in your nose. But the closing your eye part has to do with the 7th cranial nerve, and I always forget which way it goes, and I never remember it. But if you can remember that, looking at that is just a helpful differential. And the second part is if you have facial palsy, basically dysfunction, with a regular stroke, then do you think you'd also have something else wrong with the extremities on down the line? So Bell's palsy is just limited there. Apparently George Clooney had it for like 11 months. I didn't know that. It sucks when it happens, and it sucks even worse when it's permanent. So that's just a kind of trivia, and I bring it up here because, again, if you run on someone who just has Bell's palsy, you're like, oh my God, stroke code stroke, whatever, it's going to cause a lot of pandelirium. You're going to go to the wrong hospital. It's going to cause, freaking out. So it's worth being familiar with it, and that's why it's kind of a class and going with that. Febrile seizures. This is going to be the mind blower. Oh my God. I meant to cover this and we'll come back at again. Febrile seizures, guys. Isaac Grillo. I'm going to call on you because if I call on you, I'll catch Christopher Fox freaking napping. So Fox, where are you? There you go. Why do infants and small toddlers and little shits like that have febrile seizures? Does everyone agree? I didn't hear what you said.
You're muted, Fox.
You were muted, dude.
You can do it. Unmute.
It's the button.
It's called hitting the space bar.
It's the increase in their body temperature that causes their brain to basically overheat and try to release that.
So they release it by getting hyperactive and tonic-clonic? Is that how you cool off?
No. It just causes a disturbance of electrical impulses, so the body can't regulate itself.
Sound pretty convincing, right?
That's my understanding of it.
Well, it's actually a case of severe hyperventilation, hypocapnia, respiratory alkalosis. So now I'm not going to change field protocols, but I believe on your sheet, let's see if it floats up here. Oh, because I got that in a separate part. When they take a number of kids and they control for pH, in other words, they put them on Capno and have them come in with fevers and everything else screwed up, the only kids you get the seizures are the ones who have a CO2 of lower than 30. Okay? The ones who have a CO2 of higher than 30 are not in respiratory alkalosis, don't. Now, the interesting question is, why does that happen? Well, because when you get a fever, what does your respiratory rate do?
Increase.
It increases. So, little home project. Next time when you guys get sick, and especially if you get a fever, take a moment to count your pulse rate. Take a moment to count your respiratory rate. And if you get a good juicy fever of like 102, 103, don't be surprised if your respiratory rate bunches up into the 30s and 40s. Okay? Why is that? Because you're breathing really fast. So it's due to hypocapnia. Low CO2, you're blowing it off fast, you can make it. You own a respiratory alkalosis. And if you guys remember, I can't pull up all the pictures at once, but if you look at the respiratory alkalosis on the little pictures, what are the other signs of respiratory alkalosis and hyperventilation syndrome, we'll call it?
Raising your total body pH and your sodium bicarb goes up.
pH goes up or pushes up. What do
Muscle contractions.
Pedal spasm.
Muscle contractions.
Low calcium levels.
Low calcium levels, and hypocalcemia causes increased nerve irritation, hypersensitivity, hence the perioral tingling, numbness, and if taken to extreme, convulsions. You can seize yourself. Was that you, Robert Aguilera? Outstanding. Are you always reading your books?
I try to.
Well, I'll tell you what, it shows. Good job. So
Thank you, sir.
all these things, I know that, I hope this doesn't sound like too much gibberish, but I'm trying to connect the dots, because you could talk about hypocalcemia, but what the hell does that mean? But if you start putting the pieces together of how your pH affects your calcium levels and how calcium levels affect your neurologic function and lower your seizure threshold, then you start putting a global picture of things together. So what does that mean for your reality? Nothing. If you have a febrile seizure, you're not going to write down, I put them on a non-rebreather mask without flow because they were hypercapnic, because Mr. Ritchie said so, because I'll deny it. Actually, I won't deny it. I'll just say I didn't say do that, because it's not a scope of practice protocol, and if you did, you better not document it. And plus, febrile seizures, what do they do on their own? They stop. No big deal. But it's something that's good to know, because in adults, you can go into a convulsion, essentially a tonic and even clonic stage, if you hypervent yourself hard enough. It's happened. It's happened twice that I know of. Both one a 15-year-old kid and one a 40-year-old woman. So just an FYI. And how's that patient present? As altered. So it's one of the considerations. And that would be basically alkalosis. Acidemia. Acidemia, elevated or low pH in the blood, typically metabolic. That's also in your ACLS, your H's and T's, your hydrogen ions. So knowing that, Mr. Martin Zabala, can you think of an example that would cause you to be acidemic to the point where it just jacks you up and alters your mentation?
Before you said the last part, I was just going to say death, but let me see. Point of alter, dehydration?
Oh, not necessarily, not directly. Anyone else think about it? Think of something.
DKA.
DKA.
DKA is an obvious one, right? And DKA doesn't typically cause you to become altered unless it goes really bad, but it can. What about aspirin overdose? Aspirin overdose is one, and not so much like, oh, I hate my life and I'm going to take a bottle of Bayer aspirin. But can anyone think of an antacid that has salicylic acid as one of its major ingredients?
Loperamide?
That's an antidiarrheal.
Oh.
But next one. I can't remember what it's called. I have to look it up. But I believe it comes in the blue bottles. And that is taken if someone's got ulcers or they've got constant stomach problems and they're chugging this stuff. And salicylic acid, along with aluminum hydroxide, are like one of the ingredients. They can overdose on it and become salicylic toxicity. So what do you do about that? It's mainly to be aware of it. I'll just give you a heads up. That was a call we had. GCS of 4, jacked up, white trash out with freaking sticks, kicked her off to the field. We had no idea what was wrong with her until we opened the cabinets and found literally a dozen bottles of antacid that she had drunk. Why did this help? Well, we checked her blood sugar and it was okay. Obviously, you're going to check that. But as soon as I found out what it was, we called the receiving hospital because we couldn't figure out why our CO2 was so low. Even breathing slowly, her CO2 was like 15 or 20. Something's up. Called the hospital. They said that answers it because they were wondering why. She had massive salicylic overdose poisoning, and that caused decompensated metabolic acidosis. The second thing I learned from that call was the blood glucose at the hand was normal, but the brain dropped to profoundly low levels for some damn reason with acid overdose, salicylic acid overdose. So, not trying to make you an expert in this. It's more that you understand why the AAIU tips or AAIU shits we have here are there. Okay? So acidemia. Then, of course, you can have just generic shock, which will lead to essentially systemic acidemia. But is it the hypotension or is the acidemia that's causing you to be screwed up? Who knows? And the last one is ammonia. What do you guys think about that? There's no one chapter that has all this in there, so I have to kind of go off the top of my head on these. Anyone? Where would be a source of excess ammonia or ammonia toxicity?
You like cirrhosis, maybe?
Liver failure? Ascites.
Yeah.
Okay, yeah, so while you're at it, think about a couple of causes of, well, a couple of ways indicators of liver failure. What are the things you kind of see that cue you into it?
Jaundice.
Okay, jaundice, which is yellow in the skin or icterus in the eyes. That's an obvious one, okay? And that may not be liver failure, that could be liver trauma.
Hepatitis.
Hepatitis, but that presents as, okay, so yellowing of the skin, because bilirubin isn't being processed. What else?
Abdominal distension.
Okay, and what's that called?
Ascites.
Ascites. And how do you know it's just not a pot gut? We have plenty of fat asses in this country. And how do you know
it's super hard. Like it's really hard.
Okay. Have you guys ever been in a waterbed?
Yeah. Yes.
Okay. You got some of the ascites, like the rest of their body be kind of skinny, but they'll have a pot gut and just kind of do this. Okay. That would be an ascites thing. All right. Any ideas on why they have so much edema? Is it just they're eating too much salt or what?
Isn't it that the liver produces or releases fluid or something like that?
Something like that. Anyone want to care to expand on that?
Is it sclerosis of the liver? The liver's got hardened up.
Well, the liver's fucked up. We'll get that out of the way. Yes, we know the liver's screwed up. But why does that cause? And I'm going to give you a hint. It rhymes with oncotic. Ooh. That scary word again. Anyone still struggling with that one?
Oncotic pressures.
Yes. A liver disease screws up with oncotic pressure maintenance. Any idea why?
Angiotensin stuff?
No.
Does it have to do with sodium leaving the cell?
No, that's kidney stone. No?
Because God said so.
Okay, what is the main thing that Could be, depending on how you define God. Yeah, he says everything happens. So what are the two things that keeps the water in your blood vessels? And the one that's most important?
Potassium, right?
Hydrostatic pressure.
No, hydrostatic pressure makes it want to go out.
Sodium?
Sodium is one of them. What's the other one?
Potassium?
No. Potassium is located where?
In the cell.
Intracellular.
Magnesium.
Fluoride.
Oh, magnesium's also 99% intracellular.
Hydrogen.
Nitrogen. It's chloride.
I will help you.
Everything.
It's not a lifeline. It is not an electrolyte. And it isn't a vitamin either.
Is it a protein? Is it a?
It is a protein.
Oh, wait.
Albumin?
Albumin.
Man. Yeah. Who said that? Was that you?
Chevy.
It was me.
Chevy.
Wait, Chevy?
It was Chevy. I learned that with Chevy. He taught me. No, actually, his girlfriend taught me that.
So you guys are probably too young to remember this, but they used to have this thing that's showing an egg and then your egg on drugs, like a fried egg. Yeah. Well, the white of an egg is albumin. And albumin is a protein that's regulated by your liver and is what primarily keeps the water in your blood vessels. It's the protein. And then the electrolyte, most responsible, although to a lesser degree, is sodium. So people that have edema from liver failure, and this is kind of helpful to know, they become edematous because they do not have enough albumin, and that's measured in your blood, and it should be, I think, 4 to 6 grams per deciliter is the amount you have. So if you start developing pedal edema and you're a boozer, and you start getting swollen, you might want to have your liver functions checked and check your albumin levels. If that starts to decrease, you may be damaging your liver. Give yourself a heads up. Dialysis is what you go to when you're like freaking screwed. And then it's actually, it's not dialysis because dialysis is treating what?
Your kidneys.
Your kidney failure. You're just going to go and get needle aspiration of the fluid from your abdominal cavity. And that's a real pain in the ass when that happens. So if the liver fails, you build up ammonia. Ammonia builds up in your body. It screws things up, and it makes you altered, and it starts to look like almost Alzheimer's. And I'm trying to find the damn video of it because it was actually a really good interview on it. So this is something important. So albumin maintains your oncotic pressure. Sodium keeps your osmotic pressure, and it's the electrolyte. So far, any questions? This is, again, I'm going to have you kind of do some videos on the liver. And how do you palpate the liver? Actually, there's a medic in the field who was doing this the other day. I was stunned. I was like, holy crap, because he had an altered patient who had jaundice, who had liver failure. And she was actually actively looking at that cause as a problem. So you stick your right hand under your right ribs, and you take a breath, and you practice feeling for it. As you take a breath, you can feel the ledge of your liver drop down. If you've ever been on an exam table when the doc does that, that's what they're checking for. If they can feel your liver sticking below your ribs when you're not taking a breath, like your diaphragm, remember how it drops as you take a breath, it pushes down. If your liver is already sticking out below that, that shows a sign of swollen liver and fatty liver. By the way, how many of you guys drink regular Cokes and sodas with regular sodas? Sugar and everything in them. Okay, if you do that, number one cause of non-alcoholic hepatic fatty liver. I'm forgetting what it's called. So stand by. It's fructose is wicked for your liver. So give yourself some love and drink something else.
I should just drink alcohol instead.
Huh? Drink alcohol instead, yeah. There's some arguments for that. It all depends on how much. Remember, everything's a poison in the right dose. Okay. Let's see the next thing on that list. All right, this is the big ones. Can you guys, do you have your little books here? Oh, let's go to hyponatremia, and then I'm going to go take a quick break, and we'll do the hypo and hyper, the glucose stuff. So hyponatremia, what is that?
Low
sodium
blood.
It's an elevated serum sodium level.
Anyone want to fix that one there?
Hyponatremia, it's a low sodium level.
Serum sodium level.
Okay. Like a hypodermic syringe or needle means below the dermis. Hyponatremia means low blood serum sodium, which is a major problem. So what do you think would happen if someone has low serum sodium?
Edema, too much fluid.
Edema, it's not too much fluid, it's the fluid's not being held where it's supposed to be.
Right.
Portions. So if you get fluid that's excess of fluid from hyponatremia, where would it go? Or where would it go to cause problems, I should say?
Interstitial, extracellular space.
Okay, extracellular, which would be the interstitial area. So when you say
Yes.
extracellular, you're talking basically interstitium.
Mhm.
Anyone want to add into that?
Wouldn't it go into the cell?
Any thoughts?
Is this hypo? You said, Mr. Ritchie.
Hyponatremia, yep.
Wouldn't the body just excrete it, or am I completely wrong? Like the water?
Okay. So are you asking if you have hyponatremia, so there's too little salt in the blood, why would the body excrete more?
No, wouldn't the body excrete water, or wouldn't?
Oh, like to try to balance it out, like basically dehydrate you to balance out the concentration?
Right. Would that happen?
Not that I'm aware of. What actually happens is if there's less salt or sodium, I should say, in the blood vessels, and the sodium goes out into the tissues, what will follow that sodium?
The water in the cell.
Water. Okay, and if the water goes out into the interstitial spaces, in particular in the case of hyponatremia, what happens to those tissues? They swell?
They swell up.
Oh, wow.
Is that everyone agreeing with that? You have swelling. Okay, so how does this come into play? Well, we're talking about hyponatremia causing cerebral edema because of swelling in the brain. So you
Mr.
can't
Ritchie.
kill yourself from that. Yes.
Is that why drinking too much water is dangerous? Because it's it's diluting the blood. Okay, so I'm trying to understand why it would cause cerebral edema.
Just exactly what you said. So it became popular when a radio show had think of the morons with Tide Pods and who are the dipshits overdosing on Benadryl now. Some chick killed herself. They did a bet on drinking water. Can you drink a gallon of water in like a half hour or some shit like that? And the person did. And they went to sleep and didn't wake up. They died because of cerebral swelling, seizures, altered mentation. So I'm going to show you quickly here. And the radio station got sued, and the usual thing happened. So this is something that's really important because in adults, it typically happens. Say you get called out to hikers down or hiker acting bizarrely. And you're called out there and you meet these people and they're coming in with their gallons of water. And one of them's just all goofy, acting weird, seizing, altered, whatever. The first condition that you might be worried about causing them to be altered is what?
Heat stroke.
Heat stroke. Okay. And how do you eliminate that as a cause?
Check their temperature.
Check your temp. Okay. If you're below 103, you're pretty much good, even with a cord. So they don't have a heat stroke. They actually don't have much of an elevated temperature at all. The next thing could be, what have you been drinking? Gatorade, fruit, food, stuff like that? No, salt is bad for you. We've been drinking distilled water the past 6 hours. And now you have the potential for swollen brain. So the next thing is, well, it's hard to prove in the field. We don't do blood tests, but that's a potential cause. What would be your treatment for that? Well, what could you ask the hospital to consider if you ran that sort of call?
You would want to give them,
Hypertonic solution.
yeah, like something.
Hypertonic solution, very good. And what do we have that's hypertonic?
Dextrose.
Well, dextrose isn't going to really work. We want to replace the sodium. But not a bad thought on that there. I had not thought about that. Sodium bicarb.
Sodium bicarbonate.
Our little amp of sodium bicarbonate has like the equivalent of 300 or 400 cc's of a bag of normal saline. I did the calculation. I can't remember what it is now. So if you give sodium bicarb, you're giving a boost of sodium, which is what people say, oh, that's a worry. But this is a possibility. We don't have hypertonic saline, so we can't do that. Failing that, you can just give normal saline because it's going to go straight into the blood for a while. And the other population where it's really a problem is if you work in an area where there's poor people, immigrants, and they dilute the feed to their kid, their formula, to try to stretch it out, that's the other common case of it. Because adults, we basically have a fair amount of salt stuffed in us. We can, tolerate quite a bit before we go downhill. But infants, they don't. And that was the first case I ever saw that was a status seizure in an infant without a history of epilepsy or any trauma. And it was the question, how do you guys, have you been watering down your feed, your formula? In that case, treatment's still the same. Stop the damn seizure, give them first head, and then hypertonic saline.
Excuse me, sir.
Yes, sir.
How is sodium bicarb hypertonic if it's an alkalotic medication?
The bicarbonate is a buffer, and the sodium that goes with the bicarbonate is saline. It has nothing to do with its pH.
Got it.
Okay? And you could do it if you look up it at 50 milliequivalents and you see a bag of sodium bicarb. So anyone want to look it up and look up the ingredients, you can Google it. I don't want to spend time, but look it up. You can actually calculate how much sodium is in it pretty easily. So take a look, 50 milliequivalents, but I'll give you a gram weight and it'll be easy to tell. So this is just an idea of, again, troubleshooting, and these are things to consider. If you never think about it as a possible cause, you will not ever address it or even bring it up to anyone else. So the whole point of this is, as a paramedic, we can only guess so many things in the field. We don't have all the tools, but there's nothing in the world that stops you from thinking and saying, hey, doc, we found all this freaking antacid. Hey, doc, they said they've been drinking nothing but water. Well, guess what? In the ER, they're going to check labs right away anyways, but they can start the treatment emergently if they know what to look for. And that's the sort of thing that, again, separates a clown from a regular medic. So, hypoglycemia. How do you guys define that?
Low glucose.
Low glucose levels, low blood sugar levels.
And what's the level is considered problematic?
Low 60.
Below 60.
Okay. And, it varies. Most labs, I think, stop at 70. I think Riverside County is like, if it's below 70, they're ultra showing signs, treat it. I think it was 80. And it's 80 or 60 watts.
Milligrams per deciliter.
Millimeters of mercury?
It's deciliters per milliliter, right? Or
milligrams per deciliter.
Milligrams per deciliter.
Milligrams per deciliter. Okay. Milligrams per deciliter. So units of measure count. So we'll say 70 is the kind of low end. What's your high normal? What is considered normal upper range?
120.
Okay. And is that a fasting level or at any time?
Fasting level.
Okay.
Fasting.
Is it important to know it's fasting? And that's actually kind of high. But so when you're checking a blood glucose, it's a fasting level. Someone just stuffed their face. The highest you should go is, anyone remember? You went to the Cheesecake Factory and cleaned them out. God, I wish they were open.
I think if you're pre-diabetic, it's up to 200.
Roughly. We'll say 180, 160. If it goes up over 160, you're pretty much in the diabetes range. So your body's control mechanism should keep it below 160, 170. If you test someone in the field, especially someone you know, and you say, oh, your blood sugar is 230, well, that's not cause for alarm. It's not going to cause a problem by itself. But this person is technically a diabetic, and if they didn't know it, you should maybe recommend they go see their doctor, okay? So That's just the side. If your blood sugar, what if the person doesn't eat for 5 days? What happens? What do you expect to see with their blood sugar?
Be lower, hypoglycemic.
Okay. How low?
Somewhere around 100 or below 100.
Okay. Are they hypoglycemic at 100?
80.
No.
60 depends.
Maybe 50s.
Depends on the person. Everybody's different.
Okay. What if you didn't eat for 10 days? Huh?
35, 45.
Oh, shit. So everyone doesn't eat for 10 days is going to be seizing, convulsive, and out of it, right?
I don't necessarily know if it would change because your body compensates by eating itself.
True.
Okay. So that's going to be good when you have the liver class. So when you have insulin, what does the insulin do in your body?
Helps the sugar get into cells.
Helps the sugar to get into cells, right? Except for the brain. The brain doesn't need it. But for the rest of the cells, it does. And it basically, insulin is there to keep your sugar levels controlled. Too much sugar is bad for you. Too much insulin is bad for the arteries as well. What happens if you stop eating and you've burned through your glucose stores? What is the hormone that comes into play then?
Glycogen or glucagon?
Glucagon. Glucagon. Glucagon is secreted by your alpha cells in your pancreas. That stimulates the liver to convert glycogen to glucose and actually then convert fats and proteins through gluconeogenesis into a source of food. It's why you can go to bed at 7 in the evening and wake up the next day. Okay? It's why you can fast for a week or 20 days or 30 days or 40 days and be perfectly fine. Because as your insulin level drops and as your glucose levels drops, glucagon increases to now convert your fats and proteins into glucose. You guys have heard the citric acid cycle or Krebs cycle from Mr. Casares?
Yes, sir.
And you guys, are you in love with the electron chain?
Oh, yeah.
You read it, right? Your 36 ATP. Did he talk to you about beta oxidation? Well, beta oxidation is the other metabolic pathway when you don't have glucose, and now your body starts to use, as in low-carb dieting, as in people in ketosis, fats and proteins. Otherwise, you have to live on sugar. So sugar is not an essential thing to have, neither are carbs, because guess what? Your body will make its own carbs. Kind of interesting crap, huh? You would not get this at any other school. You have to get, even if you can't do shit with this in the field, this stuff you never get anywhere else. So it's cool stuff. A reason I bring this up, and there's always a reason, is so you're not one of those dorks that goes on someone who says, oh, I haven't eaten 18 hours. Oh, my God, they must be so low on their blood glucose. Now, why do people go low in blood glucose? Who are our patients who go hypoglycemic and seize?
Diabetics.
Type 1 diabetes.
Type 1 diabetics. And sometimes you can have type 2, but there's something in common with all of them. And that is they take a medicine to lower their blood glucose. And it's really easy to overdo it. That kind of ring a bell?
Insulin.
If you find a diabetic who's not diagnosed, what is the way you find that diabetic? They didn't know they were diabetic. You discovered it because you did a particular test on them and you found out, holy shit.
High blood
glucose.
Super high.
It's going to be pegging your meter to where it doesn't read. Because what do you guys' meters go up to? 400, 500?
500.
500 reads high after that.
Get high, right?
Yeah.
People that have never been diagnosed with diabetes don't show up at the hospital hypoglycemic. They show up. They had no insulin. The sugar could not get into their cells. Bam, it goes super high. Is this clicking with people? Is this clip getting together here? So now that brings in the shock question. What are the 3 Ps? Nice. You just need a little freaking feather bra on there, TJ. Did you see that there? So
I'm trying to stay.
what is the 3 Ps for undiagnosed diabetic hyperglycemia?
Polydipsia, polyuria, polyphagia.
Polydipsia, polyuria, polyphagia. What is a polydipsia, Michael Moore?
Polydipsia is excessive thirst.
Okay, and Jarek Saldivar, polyuria.
Frequent urination.
Okay, much frequent urination, right? And Bo, polyphagia. Rolling on to Zach Torres.
Extreme hunger.
Excessive hunger, okay? So what do you think starts first?
Polyuria.
Polyuria, you're pissing out a lot? And why
Yes,
does
sir.
your body piss out so much?
Because you have too much
Polydipsia.
acidosis.
It's
You have too much keno acid.
to get rid of the sugar. If your cells don't absorb the sugar, what did your blood glucose do? Skyrocket it. When the blood glucose goes up, it is hypertoxic to the body. It starts causing glycation byproducts, hypertension, hyperosmolar strain, the works. It's toxic to the brain. So your body starts to piss it off to freaking basically save itself. And then, of course, as you're shitting out or pissing out all this urine, you get thirsty to replace it, right? This is why on the sample history, it's so important to check those inputs and outputs. You never know what you're going to find. It doesn't hurt to ask. So ask, is your peeing normal, more than usual, less than usual? If it's less than usual, I got to consider things like shock, bulimic issues, kidney issues. If it's more than normal, and oh my God, let's check your blood sugar, it's 240. How have you been eating? No, I eat like a horse. Yeah, she freaking had like 6 eggs, 12 pancakes, and a half side of ham. And that's before it even finished running away. Okay? Well, there's the polyphagia for you. And why'd she call in the first place? Because she feels weak and tired. Doesn't know why. Can't stop drinking water. Kind of putting some pieces together. All those questions have a reason, guys. So the polyuria, pissing it out to save your life because the sugar will kill you. They need to replace the water from somewhere. And then they also are hungry because the cells can't get the sugar they need because the insulin isn't there. Ketoacidosis is a separate thing where you have ketones all the way through the roof. And basically it's a pathologic condition and no one knows exactly why it happens. So far, how you doing?
Mr. Rich, I had a question. Couldn't the excessive eating cause the diabetes to get even worse, especially if they start eating like,
Yeah, it's a vicious cycle because the food's not going anywhere. And typically they're drinking fruit drinks and stuff like that. Anyone ever got called to an ophthalmologist's office or an eye doctor's office to pick up a newly diagnosed diabetic? No one really? When they go check your eyes or looking at your blood vessels in the back of your eyes, ophthalmologists pick this stuff up all the time. The blood vessels are damaged to the eyes. Oh, guess what the leading cause of blindness is in the U.S.? Diabetes.
Diabetes.
So, and if it's killing the blood vessels in your eyes, guess what it's doing to your kidneys and brain? Leading cause of renal failure, uncontrolled blood sugar, poorly controlled diabetes. Diabetes is literally fucking killing the world. And actually, it's not killing the world, it's killing the economies. You ever notice how popular dialysis centers are? You want to get rich? Go in with Dr. Shibabi and fucking buy shares in a dialysis center. Be rich. That's all they do. Kidney failure leads to hypertension, leads to the whole cascade. So it's pretty sad. I'm kind of hungry. So that's the deal with the diabetes, the hypoglycemia. And now I'm going to come to the one that kills you. So DKA, what are the signs of DKA?
Rapid breathing, Kussmaul respirations.
Yeah, Kussmaul reps.
Hyperkalemia.
Okay, and do you guys, I've shown you the video of Kussmaul's respirations. Do you need to see it again? If you do, it's on the page. It's worth looking at. It is not labored breathing. This is not someone you freaking start bagging. Leave them alone. Give them fluids. Because what they really need is fluids. You run a diabetic in the field, that's kind of standard operating procedure. Get a line and breathe, give them fluids. Let's go to a diabetic that presents as shortness of breath. Can you imagine a situation where someone who takes insulin calls 911 because they can't catch their breath?
Hypoglycemia.
COPD.
For hypoglycemic, what are you typically called for? They're altered, right? And commonly seizing. By the way, if you have a seizing diabetic, stop the seizure first. Giving them the Versed, stop the seizure. Then give the glucagon or dextrose or whatever. But every moment that seizure goes on, because the seizure is driven by the neurons in the brain, they're like on empty and they're going emptier. So you've got to stop the seizure. Remember, the seizure is stopped in the brain by the Versed, not the body. It stops those nerve cells from firing off and going basically into the central nervous system version of VFib. Unless you have an IV already established and you have dextrose handy, stop the seizure first. Then immediately try to address the cause of the seizure. So Robert Butker has insulin-dependent diabetes. He decides he wants to go to Texas because they've got a freaking hog hunt going on. I'm just assuming. And so he gets on the plane, flies over there, handy mask in hand, rifle in the freaking luggage, and lands in Texas. Holy shit, we're going to go boar hunting. 2 days later, kind of feeling kind of sick, and just breathing. His friends are saying, hey, Bo, why are you breathing so fast? You ain't done nothing yet. Oh, I'm okay. I'll be okay. Go out there, breathing now faster and deeper. Hey, Bo, what's wrong? Why can't you stop breathing? I can't stop breathing fast. Well, we're going to call 911. I'm assuming Texans say 911. They probably not. So a wagon comes out there, and one of their 540-hour trained paramedics rolls on out there, and he sees you huffing and puffing and just standing there, and people are worried. They take your bucket hat off, and what's wrong with you, mister? He says, I can't catch my breath. I feel really weak and dizzy. Well, all righty. Well, let me check your blood sugar. And he checks it, and it comes back high. You know you have diabetes? Yeah. You have insulin for this? Yeah. Where is it? At home. True story, except her name was Roberta, and she came from New York to visit Fontucky. Complaint was difficulty breathing because she's breathing 40 times a minute. Fire went hoo-yah, threw her on a mask, was all about to start bagging her. I'm like, what problems do you have? She goes, I'm diabetic. Oh, really? Take insulin for that? Yes. Where's your insulin? 3,000 miles away. So it's a thought that this can present as a respiratory issue because the respiratory system is doing its damnedest to buffer the hell out of it. And yeah, you would get the polyuria, polydipsia if you ask a couple more questions. So what's the treatment for that person?
Fluids.
Fluids. Basically, don't let them go into shock because dehydration is shock in slow motion, okay? So give them the fluids, and that's exactly what they'll get at the hospital for a while, and they're going to go to intensive care for sure. So HHS, Mr. Isaac Garcia, Jonathan Garcia, HHS. You know what that is?
Not right off the top of my head, sir.
Michael Moore, you're a smart guy. Joanna Castillo, you worked at Loma Linda Pediatric Hospital. You should be familiar with this condition.
What is it? HHS?
Yes, HHS. And it's not hyper-Hispanic seizure either.
I'm trying to think.
Brian Ferguson.
It's a hyperosmolar hyperglycemic state.
Syndrome. Damn good. Okay. And it used to be called another name. It was an extra letter and it made it even harder. They call it non-ketotic hyperosmolar hyperglycemia or something. It was way too hard to remember. So Andy Escalona, hyperosmolar hyperglycemic syndrome. What can you tell me about that? Think of the words. Anyone else can add to it. What are the words saying? They're all small words put together to make big words.
High blood sugar.
High osmolarity.
So we have hyperosmolar, right? So super, we'll call it dense, okay? Fluid, like way too many osmoles in the fluid. Hyperglycemic, high blood sugar. And then syndrome means it's just shit working together to cause a problem. So what is the presentation? What is the problem with this condition?
No ketones.
They don't have high ketones. Remember, DK is kind of a syndrome, but not everyone develops ketosis or ketoacidosis. Well, what it is deadly. DKA kills relatively few people because it's pretty gradual. You have a lot of warning signs that happen. Okay. But about 10 to 20% of diabetics are diagnosed the first time they go to the hospital or when EMS runs on them for something else. They don't know they're diabetic until you do glucose. And holy shit, they find out you're diabetic. Okay. But hyperosmolar hyperglycemic syndrome is typical more in kids and teenagers. It's becoming something of an epidemic as our country's health goes further and further into the toilet. And they're finding these kids are comatose in profound shock because they have essentially pissed themselves stupid. They go into anaerobic metabolism because they don't have any circulation because they're basically circulating syrup. So what is the glucose levels in these guys?
Like 2,000 to 4,000, right?
Super high.
High. DK, you could get DK with a glucose of like as low as 300. And typically like 300 to 800. These HHSers, they'll show up with 2,100, 1,500. My brother's a mechanic in Texas. That was just a pure coincidence. One of their 20-year-old mechanic that up there that died. He went down in the shop. When they got him to the hospital, the glucose was close to 2,300. He was dead 3 days later. He was just shot. So what do you, just the key to look out for is on this patient is I think there's a 10 or 20 something % fatality rate because it's not picked up. And you guys already know better. If you have someone who's down and they're altered, you're going to check their glucose, period. You find a person like that, they're going to read high. They won't have ketone breath. They won't have that kind of acetone, deep hyperventilating breath, but they're usually altered. They will be tachy, tachypnic, low CAPNO score, and hypotensive and altered. And no history of diabetes. Most of the time, they don't even know. And it's typically the teenagers and older kids, like middle school. So if you got that, it's pretty simple. I'm covering this because it's a condition you need to be kind of aware of. Is this going to be a blood glucose higher than you can measure? And what do you think your treatment is for this person?
Fluids.
Yeah, they're hypovolemic shock. You could say dehydrated, but you could dehydrate yourself to death. So they're in hypovolemic shock. So treat that. It's going to be fluids. This is one of those ones where if you couldn't get a line because you're shot up, totally hit them with a humoral IO and nail them. This is definitely fluids. Fluid C. And I already went to the hypothermia. So I'm going to cover, first off, I want to stop for any questions or any need for clarification on other stuff.
No, but I really need to go to the bathroom, so.
Oh, go to the bathroom. Just leave us here, though. Saldivar?
Yes, sir.
Anything? Okay, so I'm going to come back here real quick, and I'm going to play a little interview for you. Let me share real quick. Okay, this is going to be another question for y'all. When you hear conditions and stuff like that, you're obviously half brain dead. You're hopefully paying attention to a couple of points, but they're all hypothetical conditions, the shit that you don't see. If you listen to the interviews, like the chick who had the PE or something go wrong with them, how much does that resonate with you? Hopefully it does a little bit. You know, you don't want to ever lose your humanity, that even though we're studying the science of medicine, it's about people. And we are people, and we know people that are going to be influenced by the same stuff. So I know for me, it helps if I've transported someone with a condition because it tends to stick in my head better. And if you make an emotional connection with someone, it's obviously more. So my idea of bringing these videos to you is not just it's not fluff. It's if you listen to them, they're going to tell you what you would find with an assessment. If you had asked those questions, what they might present as. And then it kind of tells you what their experience was. Because guess what, guys? Most of us are going to get something fucked up with us in the future. Whether it's cancer, diabetes, heart attack, stroke. And so don't pretend just because you're in healthcare, it ain't going to happen to you. So that's the intention. So hopefully you get that out of it. So let's see, does that share? What do you see now?
Lady.
Okay, good. Except for some reason, here we go. I'm going to play that. So this is a hepatic encephalopathy.
I started noticing symptoms when I would ask the same question multiple times within a few minutes and not remember the answer that somebody told me.
They test your hands because they call it flappers, and your hands will, you can't really keep them steady. They flap and they flap. And when that starts, that's when you know you're getting the toxins. It's kind of a process where you know certain things are not good.
And it started small, and then progressively got worse over the course of time. And there was one specific time I got in the car, started driving home from work, and I came to in the car while driving. Now, obviously, I was still driving okay. We didn't crash or anything. But at the same time, on my way home, I looked at where I was, and I had to look to the left to realize the sun was setting. And I noticed I had my suit and tie on that day. So like, okay, I must be coming home from work. The problem was I had passed my exit by about 2 hours.
You can't remember anything. You're shaky. You feel like you're 80 years old.
Just crawled around the house. Didn't know where I was. Couldn't talk. Couldn't walk. Crawled. Tried to bust through the walls because I couldn't get out.
And then one day I walked in, and my husband, Michael, was holding the remote control and his cell phone. And he said, "I'm not sure what these are. I know you press them to do things, but I'm not sure."
I was having some problems with fluid in my abdomen, and I just was really tired and really just feeling kind of bad and feeling kind of just irritable and really exhausted. And so I went to a doctor who recommended me that I see a different doctor, and then that's when they found that I had something called ascites on my abdomen, which is fluid building up in my belly, and that is one of the symptoms for cirrhosis. And so that's when they sent me to a specialist, and it was confirmed that I had decompensated cirrhosis. So, and as soon as I was diagnosed, I started to get really sick really quickly. So I was in the hospital probably within 2 weeks of being diagnosed.
They were testing my ammonia level, and they noticed that it was elevated. But they primarily went on the symptoms that I was having and the severity of the forgetfulness and the fatigue. And then that's when I was diagnosed with hepatic encephalopathy, or HE.
So kind of looking at the AAIU tips thing, again, it's not meant that we can cure all those things. It's meant you kind of keep your mind open for possibilities, because it can kind of shape your questions a little bit. Okay, and I hope you can kind of imagine some of those calls, like the guy who woke up basically somewhere else in the car. You know, everything's checking out that you can find. It may not make a bit of difference in your assessment, but it doesn't mean you don't need to be or can be aware of it. So you got the encephalopathy. No one knows exactly how it works, but they just know that the ammonia and something else happens to screw up your brain. So what does encephalopathy mean, Matthew Barber?
I don't know. I was kind of hard to understand a little bit, but like basically it causes to where, or one of the symptoms, you forget things or like forget what they are. And then they were talking about ascites, so I didn't get that at all.
Okay, anyone want to bring into that?
The loss of brain function because of the toxins being built up in the blood.
So you have ascites. Remember, the liver is what regulates and produces albumin. If you don't have enough albumin in your blood vessels, then it doesn't hold the water in, and that water leaks out into your tissues. Okay? And your main hepatic circulation is in your gut, so the peritoneum becomes the natural place for it to sit. It can also happen dependent, like your extremities as well. Kind of ring a bell. So that's the issue. And then what was the other part you said? The encephalopathy just means
it's the brain damage.
The brain, yeah. Anything could cause it. Anything that screws it up is just a generic term. So you can get it from parasites, worms. Anyone been in Mexico here or lived in Mexico? Yeah, allegedly, is there some sort of the parasites that everyone knows of down there? Care to say anything about that?
Yeah.
So
it's about 20 times.
So clearly, it's not going to be something that we're not going to be able to really tell, but it's something to be aware of, and that's why I ask people that have new onset altered LOC. I'll find out if they've been out of the country. They traveled, They've been somewhere because if you ever see kind of the medical mystery channels, sometimes it comes down to someone went to Africa, they went to Malawi, all of a sudden they're acting weird. What happened? They got bitten by a tsetse fly and now they have sleeping sickness. Well, if they showed up in New York 6 weeks later, no one even knows what to check for. But if you have that history, it could be useful. I can't make you remember that. None of us remembers everything, but the more you're aware, the smarter you kind of think. Oh, well, shit. Have you been out of the country recently? The only reason we started asking that now is because of what? COVID. A few years ago, why were we asking about travel to Africa?
Malaria.
No. Malaria.
The Zeke.
No. No. Ebola. Now that's some scary crap. So, last one. Ready? This is near and dear to me, and I'll hit it again and again. It's the hyper and hypothermia. Okay? So hypothermia is kind of, what is it, when your temperature goes below like 91 Fahrenheit, then you basically start to run into altered mentation, into obvious hypothermia. Hyperthermia, specifically heat stroke. So I'm going to ask Alex Fuel, what do you know about heat stroke?
Heat stroke, well, obviously it's an elevated temperature, body temperature for that. It's kind of like when your body's kind of shutting down to where, is it where like you're stopping, you're not sweating anymore?
Okay.
Yeah.
Anyone want to add to this?
Yeah, you just.
Go ahead, Charlie.
Go ahead, Aguilera.
I just know about the temperature of 104. You usually you present yourself with a temperature of 104. Like Alex mentioned, you lost your ability to like sweat. You're usually dry and warm. So you're pretty much going on the downfall at that point.
Okay, so good. Everything's been right there except for the parts that are wrong. So I'm going to pop your heads. And did you know there are basically two types of heat stroke, and they're both deadly? There's your exertional heat stroke, which is a heat stroke that you get because you are exerting yourself and your temperature skyrockets like within minutes. Bo, can you hear me? I know your picture is on there. Who's played football in the summer in a humid area? Okay. Who's been in turnouts on a structure fire in the summer? About how fast did it take you to get hot as shit?
1 minute.
15 minutes, easy.
3 minutes. 1 minute.
Okay. Exertional heat stroke, both heat strokes kill you by you overheating. Exertional is when your own body temperature is generated because you're exercising, and it becomes compounded if you have PPE on, and it's even worse if you have a humid atmosphere. You ever wonder why you sweat more in humid atmosphere? Hey, honey. Do you sweat more in a humid atmosphere?
Yes.
Okay. Or are you sweating the same amount, but your sweat doesn't evaporate in a humid atmosphere?
That part.
That part. Because part of how sweat cools you off is by its evaporation. If it doesn't evaporate, it doesn't do anything. So think about this. You ever taken an alcohol prep pad and wiped the skin? And how cold it feels?
It makes you cold, yeah. Well, it feels cold.
Why does it make you feel cold, Brooke Barker? I waited for your mouth to be full to ask. What does alcohol, because of its volatility, or gasoline for that matter, what does it do? Is it evaporate faster or slower than regular water?
Like the alcohol itself in the body?
No, alcohol on the surface of anything. If you splashed some rubbing alcohol and then you splash some regular tap water on a table, which would evaporate faster?
Water? Or no?
Rubbing alcohol.
The alcohol.
The alcohol.
Okay. If you put that same alcohol in your skin, it evaporates faster, and that's why it feels so cold. Okay. And I'll give you another analogy, because this is really important to learn about convective heating. You ever been in the water and it feels okay, maybe just a little chilly, but you step out and there's a breeze and now you're freezing your ass off?
Yeah.
Why is it colder when it's breezy?
Because the wind is hitting you?
No, because the wind is doing something to the water. It speeds up how fast it evaporates.
Oh.
Just like we have fans in our ceilings to blow on us to make us feel cooler. Why? The air isn't cooler. It's because it helps us sweat evaporate faster, and we almost always have a little moisture on our skin. So evaporation, the act of evaporation requires energy, and that energy is pulled from your body in the form of heat. So as creatures, we cool off really well when the air is dry, and that's why they call it a dry heat, because your sweat's evaporating basically as fast as it comes off. Whereas if you go to Florida or Texas, you're just drowning in sweat. And you feel miserable because
it's so humid.
Does it make you hotter, or like, do you feel hotter in a humid climate, sir, because the water doesn't evaporate and then the water just holds the heat on your skin?
And the water doesn't evaporate, and it doesn't so much as hold the heat on your skin. It cannot pull it away, because for water to evaporate, it needs to have enough heat to cause it to loosen up and basically boil off. Okay, so I'm bringing this up because we got a couple of videos, and that'll be pretty much wrapping up this period. Because the biggest fallacy about heat stroke is that it has to be really hot outside and you have to be dehydrated. Both crap. You could be fully hydrated and die of heat stroke because you can't cool off. All right? The hydration issue is much more of a factor for heat exhaustion. But heat exhaustion isn't included in the AIOU tips because heat exhaustion just makes you feel miserable, weak, you might cramp up, fall over, throw up, but you're still not altered and you're not hyperthermic. You're just miserable as shit and you're dehydrated. With heat stroke, the number one sign of heat stroke, I should say, 2 signs of heat stroke. Grillo, where are you? Don't disappoint me. All freaking last year, I brought this up. 2 signs. Rhymes with 2 letters.
2 letters. I don't know, but you got dry.
Right now. Can't do this anymore.
You got your dry skin. You got flush skins. God.
Wow, you killed him, bro.
I know.
Right. You know, I said I liked you. I lied.
Yeah.
Zabala, I don't have any intestines left. Go ahead.
I'm not sure exactly what you're looking for, but we know that we're looking for 104 degrees, but high body temperature. Skins are going to be red hot and dry.
Okay, hold on a second. Wait a second. Where's the black people here? Eric?
How you doing?
What color does your skin turn when you're red?
I'm a little bit whiter, so it turns red.
You're kind of mocha, but you'd still be freaking, we'll call it there. Or we got Ferguson. Or we have Saldivar. We're the Chinese population. What is red and yellow going to do? Zabala, that's it. You're a racist.
Chris.
Hot and altered. Ha.
Oh, is that heat stroke?
Yes, heat stroke. Yeah, by Star Pupils, Pimp Daddy, Boxer at the gas station, and YouTuber still forgets what. In 10 minutes. What a disappointment.
I miss Zucci.
I know Fox was fucking hiding back there and just pretending he didn't know. H-A, keep it simple, hot and altered. And if you prefer to say you can just say altered and hot. That's it. Because exertional heat strokes are often sweating and pale. Get the idea that heat stroke looks like anything out of your head. It has been written on over and over again, and it's a myth that's perpetuated. Okay? I've got papers dating back to 1915 from Lawrence of Arabia and the medical staff there saying we need to tell people to stop looking for hot and dry and flushed skin because everyone here is black. Doesn't work. Does that mean you can't be hot and flushed and dry? Yeah, you can. But that sure as hell leaves a whole lot of people out of the equation. So I'm going to kind of sum it up, and I'm going to have you watch this little video here. There's a couple of them. By the way, you know who led the charge on this? The National Athletics Trainers Association. Because guess what the third leading cause of death of U.S. high school football players was until the past just few years?
Heat stroke.
Heat stroke. You know why? Because dip fuck coaches were looking around and saying, oh my God, well, you're sweaty. You got to be okay. Get back out there.
Yep.
And drop dead. And then paramedics get on scene and find their heart rate's 170 and try to cardiovert them when they don't know their temperature is 109 degrees. Went to Loma Linda. Hot and altered. Don't worry about what they look like. Sweating or not. I'll come back to that. But coaches started to get fined. Schools started to get nailed. And military started busting commanding officers for heat casualties. It's only in EMS that we're stupid still to this day and don't cover it right. So, ready to play.
Mr. Ritchie, was that also the article you shared with us last year about the U.S. Forest Service? Or is that on Rhabdo?
Rhabdo was a separate condition, but same basic cause. Hyperthermia will cook you, and if it cooks you, it destroys your cells. And if the cells die, where's all that potassium trapped, boys and girls? In your cells, 99% of it. And if the cells are destroyed, what happens to that potassium? It gets liberated into the serum. And now you have hyperkalemia.
Muy malo.
Muy malo, yes. And then, of course, your heart can't maintain its polarity, and you have cardiac instability. So let's look at this here and see what they've got to say. Hopefully that works. Is it showing that screen or not? This one here? Is it showing that or not?
Yeah, it's showing.
Okay, because no one's answering, and I can't see what you see. So.
Yeah. So here's the message for remembering it. And I'm going to start off with the clinical features. So clinical.
Oh God.
Forgetfulness.
Forget it. It's dumb. Let's go to the other one here. I just pulled up a couple just in case. Let's see. The military is the best one right now. In fact, that's what I used on my fire engine after seeing that. And why I harp on this? Because any heat stroke that is missed by EMS is negligence. That is truly the most reversible thing you can do. You do not load and go, you cool. You cool them off. So let's start with football here and try this story.
And how do you feel like the specific the system kind of this run heavy system kind of fits your skill set as well?
I mean, I think it's great. You know, college football, you can run a fast tempo. You know, the option play that we have and all that stuff. It's you know, a little wrinkles that blow out defenses on their heels. So I like that. And, I think as a whole unit, we're really picking it up really well.
How much thinner did you play in Miami? How you think it's
Yeah, so I played my first 2 years before I got here, I was center, and then the year after I get my first year back, I played center, and then my last year I played tackle.
You played more center than anywhere.
Yeah. Okay. And also, just kind of walk us through the incident that happened at Miami. Just what was that like for you, and what kind of made you say, hey, I'm still going to keep playing even after that?
Yeah. So I mean, first of all, like there's kind of a misconception that like there's some freak thing. I was sick that day. Okay. It wasn't hot or anything like that. So I knew if I wasn't sick going forward, I'd be fine. So after I rehabbed and all that stuff, I really just was able to put that stuff behind me. And I really enjoy this game. I like hanging out with my teammates. I like to grind over it every day, and I really wanted to be back with that.
And how scary was that day for you just going through that?
I don't remember a whole lot. I blacked out and all that stuff, but the memory kind of freaked me out for a while. You don't realize how close to death you were. Especially when other people are telling you and all that stuff. And you're like, wow, that really happened. I'm very fortunate. I know every year there's kids that die from heat strokes and playing football, so I'm very fortunate. Even more fortunate to still be able to play.
Okay, that didn't give a whole lot there.
He low-key sounded like that guy from The Waterboy.
Comedy?
Yeah, I did not understand a word he said. He says, blah, 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 blah. I honestly thought the reporter was having a heat stroke as well because he wasn't making a lot of sense either.
So, yeah, actually it was kind of like, what the heck here? So I'm going to see this last one. Actually, because it's going to take too long, I'm going to cover it, but I'm going to come back to this. So I'm going to give it to you quickly now. And the 17-year-old exertional heat stroke. Heat stroke is a leading cause of death in young athletes each year, with the incidence increasing annually. This is a paper dated American Medical Society for Sports Medicine, 2002. Okay. So I want to go to the two types of heat stroke and try to make this easy. So I'm going to stop the share. The classic heat stroke, which we all learned in school. You turn hot, it's super hot outside, you get dry skins. This is the sort of heat stroke you'd find in a couple of situations. One, especially in this area, is a kid who's locked in a car. Okay, someone who's left in a car, it gets super hot outside, and eventually, you'll sweat at first, but eventually you overheat to the point where your central nervous system stops working, and your temperature skyrockets. Essentially, your compensatory systems failed. That's the sort of person you'll find dry, and whatever color they are, either baked or red or whatever. It all depends on when you find them. Okay, this is what they call classical or non-exertional heat stroke. Rawlings, no, who was the other guy who went out? The Blythe from the last class. He ran a heat stroke. It was
Jacob Hestelin.
Hestelin ran it, and that was a bum out there, druggie or whatever, outside the back. You find those in the desert, and those are sometimes guys you find just under a bridge or whatever. And that's a non-exertional heat stroke. It almost always takes a high outside temperature over time. That accounts for most of the heat strokes in con homes. You guys remember Hurricane Sandy in Florida? They lost power, and they found a lot of people died in the con homes there because they had no AC. These poor people are stuck in bed, jacked up, OBS, whatever's wrong with them, and they wind up dying of heat stroke. They're going to be dry skinned. It develops over hours. In the early 2000s, they had a massive heat wave in Europe. Over 40,000 French and Spanish inpatients died. And that's because they don't have air conditioning in a lot of the buildings there. So when the temperature goes through the roof, they got nothing. Ordinary people go out and jump in the water, pop hydrants, drive in a car just to stay cool. But people who are bedridden, they can't. Non-exertional heat stroke. The temperature is going to be over 104 degrees, and that's not even necessarily true. You can actually be higher in some athletes, but they are altered and hot. If you don't have a thermometer, you check them at the base of their neck. And then if you don't know, check someone right next to you in the same conditions. If you ever felt a heat stroke, it's hard to mistake how hot they feel. And then they're not there. Typically, in the exertional or the ones I described, the person will be comatose. Sometimes they'll be seizing, but a lot of times by the time you get there, they'll be comatose or PEA and basically dead. Treatment is rapid cooling. Rapid, not how many guys have ice packs in your ambulances? Really? Do they melt?
No, mine's only got a break and check up.
Because you don't have ice packs, you have cold packs.
Yeah.
Okay? None of you has ice packs. The only people that have ice packs are fire engines, or if you can throw some ice in your chest for your drinks. All right? So that's the first thing. And they're almost useless for cooling heat strokes. The ice pack in the crotch and underarms, it was been measured, tested, and compared, and it's like almost as slow as just letting them sit there. It's really pointless. If you're going to cool them evaporating with active cooling. Exertional heat stroke. The lowest temperature, can anyone guess the lowest temperature an exertional heat stroke has been documented at? Blew my mind when I heard this.
100
degrees. 49 degrees Fahrenheit. In a runner in a marathon. Boston Marathon. What is Boston? Humid. 49 degrees. Documented. Got the papers. I've got hundreds of files on it. Okay. Typically at Fort Benning, they were running around 6 or 7 heat strokes a summer. And when does the military typically PT? Frickin' 0 goddamn dark 30. Okay. They're getting heat strokes at like 5:30, 6:30 in the morning. But what's the humidity like at Fort Benning? It's so wet, mosquitoes need scuba gear. Okay. It's always humid. It sucks. They are getting overheated because they're exercising. Now, this is a nod to women everywhere. Guess which type of athlete gets heat stroke most often? Stupid guys. And usually stupid strong guys. And characteristically, the three groups that get them most are firefighters in an academy setting, folks in boot camp, and athletes on a team. Why do you guys think that is?
Pride.
Pride.
Yeah.
You don't want to quit.
Ego, yeah.
Okay? You don't want to quit. And I'm going to bring this up as a leadership issue for you guys later, for those of you in a position of leadership or authority, because this is important. Heat stroke is a leader's or partner problem. The person who has a heat stroke won't know it. You don't know you're having a heat stroke. Every heat stroke I've run, they don't remember shit. They're amnesic to the event. That one guy there doesn't remember a thing. Okay? He was told what happened afterwards. They become altered. They don't know what's going on. So when I have my fire crews or we're on a hike, first thing I do over there, I say, Melendez, what's going on? Melendez looks back at me. I can see his freaking full deck of cards. He's good. He's zoning out. He's not acting right. Something's wrong. He starts hiking up the wrong trail. Hey, Melendez, get back here. I need to catch that praying mantis. There's a pool over there I need to go swimming in. Get his ass down. Check his temp. He's altered. Start freaking cooling him. And he may fight. Okay? You let him go further than that, typically the next step is convulsions. Next step after that, cardiac arrest, presenting as a PEA. So it's always cool to read about a firefighter who goes on a 30-minute run in Texas. 30 minutes. Big dude. Lots of muscle mass, right? Guess what generates heat in your body? Muscle. Why aren't more fat people having heat stroke? Because fat people aren't doing the running. But if you're that perfect mix of like strong and pudgy and good shape, you're like the death sentence of heat strokes. Add to that, you're taking benzos or anything to like a cold. They overheat, and the guy's staggered. What do you do at the end of a formation run? Anyone been in an academy run with a class? Come on, dude, you can make it. Only another quarter mile. Yeah, I could do that. Next thing, he becomes ataxic. He's starting to wobble a little bit. Next thing, he goes down. What do? Oh, shit. He ain't breathing. Or he got no pulses. Call 911. Ambulance shows up. What do? Defib him, run him. They never check a temp. And going back to Isaac Grillo, I'm going to harass you. You got to learn something one of these fucking years. I don't care if you have to graduate in class 35, okay? You become super hyperthermic and your temperature, core temperature is exceeding 107 degrees. What do you think your serum potassium levels do? Up. What does your cardiac resuscitation do? Go shit. Because if you don't tell them they're hyperthermic, they're not going to consider it. Even though everyone goes H's and T's, no one actually checks it. And the person dies, and he's 23 years old, and they make a 10-page NIOSH report, and now that's why all fire academies are required or recommended to have immersion chambers with ice water or basically high-volume water supply with ice packs nearby. These are always young people, because old people are too smart to go out and get heat strokes. We'll quit, right? When you're young and dumb, you want to impress people, that's when you have it. But you're not free there, Joanna, because a U.S. Fire Service fire captain ran 6 miles a day, and one day on the end of her run on a hill, nice and cool, decides that she saw a lake where there was no lake, started clambering up a fence, and her crew had to chase her down and found out she was bizarre behavior heat stroke. So guys, I have countless examples like that. And you don't even have to remember anything but 2 letters. If they are altered and you got a tympanic or axillary temperature that's freaking solid 104 and up, or they feel hot, assume they're heat stroke. So now let's get to the important part. What do you do for treatment? Load and go?
Active.
Cool area. Cooling measures.
Faster, the better.
Fluids.
Call them over. No, cool them first. Fluids is, if you can do it simultaneously, by all means, give them fluids because they're probably got kidney damage and rhabdo and everything going on. But I'll give an example of just one last one as a war story, only so you can remember it. I've run about 8 heat strokes. The very first one when I was in the Marines, and I was an NCO of the Barracks. We came back for our typical every stupid day run, and one guy just started acting weird, looking weird. I went to the head, hear screaming in the barracks. He's on the ground convulsing, tonic or clonic seizures. I said, grab his ass and drag him into the shower. He started screaming. We stripped him, held him underwater, sent someone to call the ambulance. Full-on heat stroke. Rapid cooling is all we could do. And 29 Palms, we got called for a head injury. This might be a scenario. Lying on her back, 80-year-old woman, pool of blood under her head. Fire department's on scene. They're high speed out there, so we called an air ambulance. She's a GCS of 3. And this was Morongo Basin ambulance. It's really cool because you wear shorts out there. So pulled up, and I'm looking at her, and you see an unresponsive person with a closed head injury, a pool of blood about yay big under her head on the ground. What are the vital signs you guys be thinking of right off the bat?
Tachycardic.
Yeah, low BP.
Low BP.
Okay, pretend we're not talking heat stroke. Pretend we're talking you got called for head trauma, unresponsive. What are you thinking of?
Everything in the dumps at 80 years old, probably on blood thinners, probably low BP.
So if you got ICP because of a bleed or head trauma, what is the typical response to the body?
Cushing's triad.
Bradycardia. So what do you expect? Bradycardia, some sort of irregular breathing, and what does the body's blood pressure do to overcome that increased intracranial pressure? It goes up, right?
Skyrockets, yeah.
So I'm not saying this like a magic. I'm saying when I got up on scene, I'm thinking the exact same thing. Closed head injury. But as I walked up to her, I noticed she's breathing really fast. And I took her pulse, and it's like, holy shit, it's like 160. I was like, holy shit, she's hot. So I got my $8 thermometer and went and checked her axillary temperature. It was 109 degrees. So what do you do then? Got a helicopter ready to land. We're out there in the sticks. Closest hospital's 15 minutes away. Closest trauma center's an hour away. And you can get her there by helicopter in, say, 25 minutes. What would you do there, Mr. Gott? I like the fact you have a dry erase board there. That's freaking pretty nice.
What was the question? I'm sorry. I was writing as.
Who was listening to the question? Joanna Castillo.
I would rapidly cool her.
How?
You
got an engine.
Okay, I would see if I could get ice from some way. Get ice. First, take her out of the hot environment. So get her maybe in the back of the ambulance where I can run the AC. Putting some ice on her. Taking her clothes off.
Okay.
Something that will kind of wet her body. And
sounds good. What about now? If you read this in JBL or EMS testing, it'll say something stupid like secure her airway, place an OPA, and bag her. Ignore that crap. That's just dumb. Okay. So pretty much did what you said. First thing I did is cancel the helicopter. Because if they got on scene and they found her with a GCS of 3, guess what helicopters just have to do to everyone? Intubate them. And what do they give as a paralytic agent? Succinylcholine. And what does succinylcholine do to your muscles? Depolarizes them and causes them to fasciculate. And what does that do to potassium levels? Blam! Blows it up. Kills them. Plus, she doesn't need that. So I asked the fire guys to get your damn ice chest, strip her, and start pouring cold water on her. What about her head? Don't care. I got the line, started running fluids. As soon as we made a puddle out of that whole area and dumped all the water around and fanned her like a Maharaja's, got her into the ambulance, and then rechecked her temperature. When her temperature came down to about 102, I stopped cooling. Because you can cool someone down really fast if you get an air conditioner or a fan. If you're out in the bush with a Type 3 engine, you don't have air conditioning, get a PPV. PPV and water, you cool down fast. And if anyone tells you the CO is a danger, they're full of shit. They don't know what they're talking about. Okay, we've measured it. It's like less than 12 parts per million. So cool them off fast. And there's a direct association with brain damage and kidney damage and how fast you cool them off. None of this gradual shit, as fast as you can. But don't forget, you want to keep taking their temp. You're reassessing, right? So take their temp. Once you get down below heat stroke range, around 101, 102, stop. Because what happens is the temperature keeps keep going down, and it may slingshot back up. If they seize or shiver, what are you going to do?
Stop the seizure.
Stop the seizure. And for all intents and purposes, shivering is a seizure in this case, because it'll generate the temperature back up and it'll rock it right back up. Their hypothalamus is shocked. And you know what? If you call a shivering person a seizure, who's going to tell you different at the hospital? Yeah, they were seizing. I have yet to find a nurse in the world that says, no, they weren't. How do you know? Well, I don't believe you. You didn't see the seizure. I did. Stop the seizure. Keep them cool. That girl, she came back out of it and lived. Complete regaining of everything with a few staples in her head. 2 weeks later, she was discharged. I couldn't believe it. I've never seen. Axillary temp, that means that's like lower, maybe 1 or 2 degrees lower than she was. Complete save. That's why heat strokes are so it's the worst thing in the world when you miss them in EMS. Check your temps. Not just for sepsis, but for those. And, one cool thing, we offloaded her in the ER, and just as soon as we turned her over to the bed for the resuscitation, she had the worst explosive case of shits ever. Cleared out the ER, the hallways down both sides, wiped it out. And we left. Thank God it didn't happen in the ambulance. It was bad. It was really bad. Legendary. But you know why she did that? Because the guts were cooking, just like in radiation injury. The intestinal tract gets ruined. And one of our engineers, he worked at 66, we went to the academy together, we got a heat stroke on a fire. They didn't recognize it. His gut's been messed up ever since. So, small war stories mainly to make the impression, hot and altered, consider heat stroke, and rapid cooling. There's no excuse to miss a heat stroke, none, except incompetence. So, guys, been a long day. Hopefully that closed it up okay. See ya.
Mr. Ritchie?
Yes.
What do we need to get ready for labs next week?
We'll need it sucks because I know exactly what you need. You need your bags, but we need airway mannequins, the big things. Because you'll have the King Airways with your stuff. Allegedly, we'll have O2 tanks filled for the CPAP scenarios, because that's what I'm trying to get is play with the CPAP, get used to it since we have so little time. But we'll have to get the airway stations, and on the syllabus, let's see what I have it. We have the King Airway intro on 2 stations, and we'll have the oral tracheal intubation, and you have all the crap you need in the kit for that. We just need the intubation mannequins. And the ones you need are the ones in the medic, the H building. They have the buttons on the end of them. It's like a torso with a fat head. And they've got little buttons so you can inflate the Fox, and those guys can show you. Those are the most realistic mannequins for our intubation. You guys know what I'm talking about, right? You know
Which one?
The intubation mannequins, they're realistic. Those are really hard plastic. They're kind of fake feeling. These ones are the big fat ones in a case, and they feel softer than normal, and they've got the buttons that you can cause esophageal swelling. And
Swelling and stuff.
So we'll need those of that for the intubation, as many as we can, so as many people can practice tubing as possible. And then for the King Airway, we just need generic mannequins, heads. That'll work. So just look at the syllabus for that. So you have the stuff in your bags, really. It's the mannequins that you need to get. Okay, so good questions. Hopefully you guys got something out of this. And I guess at this point, just see you next week.
Do you need... Are we doing 4 squads or 5 squads next week for the lab?
The physicals, it's 5 squads. So from now on, when we do, I don't know if you were here for the Zoom labs, because of the fact that I got to keep getting people in class. It'll be 4 rooms, 4 Zoom rooms. But for our physical labs on campus, we're still spreading it out to 5.
Sir?
Yeah.
One last question. For homework, is it just chapter 15 and the videos, right? That's due next Wednesday.
Yeah, the date, everything's dated on there.
Sweet.
Not all of chapter 15, but it's, I want to say, about probably 10 pages. Some of them are pictures. So it's nothing crazy. And
yeah,
videos. So, and what I'm saying, I know you guys got other reading to do, but don't let this be like that's all you need to read. Okay, the way you're going to get ahead of this is by every chance you get, do a bit of reading. Okay, it's really like you're nibbling away at that book every chance you get. If you just kind of jam it like one long study session, half the shit goes in one eye and out the other.
Yep.
So, anyone need to reach out to me afterwards? Again, Saturday or Sunday. Who works on who? Basically, if you need to get a private session or a Zoom thing, or even meet on campus to practice some crap, let me know, and I can usually get there on Sunday. So. But you have to let me know. I'm not going to chase you down.
Copy. Thank you, sir.
All right. Any other questions? Very good. I'm going to let you go. The wife is here. Bye.
Thank you, sir.
Ciao.
Thank you, sir.
Thank you, sir.
Thank you, sir.